Hello friends, this is Dr. Nikita here, your radiology faculty on the platform of Prep Ladder. And here we are to discuss snapshot, that is all the high yield images in radiology. So this is going to be like a last minute revision of all the important images in radiology. So we would be going stepwise, that is first a quick images in the general, the basics of radiology. Then we'll be seeing the investigations, identification, then the normal anatomy. And then we would go system wise to look at the various pathologies. So starting with the general, that's the basics of radiology. What is this image showing? So this image is showing a X-ray tube. What does the X-ray tube does? Basically, it produces X-rays, right? From the fast moving electron beam, the sudden stoppage that produces the X-ray beam. Now in this X-ray tube, we can see that we have a cathode and we have an anode. How do we identify the anode? Anode is a rotating anode, so it has bearings attached to it. What is the cathode made up of? Cathode is made up of tungsten plus thorium. And what is the anode made up of? Anode is made up of tungsten and rhenium. Anode is made up of tungsten and rhenium. Anode in mammography is made up of molybdenum, right? So remember, this is the X-ray tube. Now, coming to this one, identify these various machines that we are seeing here, A, B, and C. So in the A image is the CT scan. It's just around the gantry. The tunnel-like thing, that's going to be MRI. And this is the ultrasound, right? Ultrasonography. So first is CT, next is MRI, then we have the ultrasound. MRI has a long tunnel, right? Out of these, which do not have the ionizing radiation? It is MRI and ultrasound which have no ionizing radiation. In CT is actually like a 3D X-ray. It has radiation exposure. So CT and X-ray, they work on the same principle, that is utilization of X-rays. Now going to this one, that is the basics, the black and white that we should know. So all these images that you see here, these are the CT images with the white bone, the white bone, the white bone, and the white bone. So what are we seeing here? In the CT image, based on their HU value, every substance has a black or a white appearance. So the one which is the jet black, that is going to be air. So air is jet black. It has a HU value minus 1000. The diagnosis here is pneumothorax. So depending on by identifying whether the pathology is black or white, you should be able to narrow down the differential diagnosis. Here, this is the kidney, the left kidney which is normal. This is the right kidney which is showing a lesion with the dirty black appearance. Dirty black on CT is fat. Fat has negative HU value, minus 50 to minus 100. So fat containing kidney lesion is going to be angiomyolipoma, right? It has the solid enhancing component as well. Another thing here, in the CT, what is this pathology that we are seeing here? Is it hypo or hyperdense? It is hyperdense. It is white. As compared to the rest of the brain parenchyma, it is more white. More white means hyper. So this is hyperdense. Okay, so this is hyperdense. Now what is hyperdense or non-contrast CT? Either it is bones or it is calcification or it is acute hemorrhage. Okay, or it is acute hemorrhage. Here the white area is not as white as the bones, and that is why it is acute hemorrhage. So remember, for acute hemorrhage, it is non-contrast CT, which is the investigation of choice. For chronic hemorrhage, it is MRI. This one, which is very, very white on CT and giving those artifacts, right? This is the metal or metallic foreign body. Remember an important point that for metallic foreign body, MRI is contraindicated. Okay, MRI is contraindicated. X-ray is the first investigation. CT is the best investigation. Right, so that's the black and white on CT. Now, what appearance does fat have on ultrasound and MRI? Also remember that on ultrasound, fat is hyperechoic. On MRI, both T1 and T2 weighted MRI, fat is white. That means it is hyper intense. Now going to the next one, what machines are these which have something like an overhead thing coming? So this machine here which has the compression plate also, this is mammography. Okay, this is mammography which has a compression plate like you can see here. And does mammography have radiation exposure? Yes, it's basically the X-ray of the breast with compression. So it is used for screening for breast cancer. Most important finding that we are looking for is microcalcification. Remember, it is microcalcification which is malignant. The next one that we see here, this machine here with the patient lying, this is the DEXA. This is DEXA scan, which is used for bone mineral density, which helps us in the diagnosis of osteoporosis, which is defined as T-score less than minus 2.5 standard deviation. Going to the next one, the contrast media. Now the name itself is written here. The first one is written, it's iohexol. So this is iodinated contrast medium, which is used in all the X-ray based investigations like contrast X-rays, that is the dye studies, and the contrast enhanced CT. This one here, gadodiamide. Gado is gadolinium based compound, which is used in MRI. It's used as a contrast in MRI. And this one which is written here, SonoView, that means this is the contrast used in sonography. Okay, this is the contrast used in sonography. And what is the last one here? Microbar. Remember, bar is the barium. This is barium sulfate. Remember, it is barium sulfate, which is the contrast, not barium sulfide or barium carbonate. Now, coming to the unique points here, before giving the CT or MRI contrast, what test do we need to do? We need to do RFT or KFT, serum creatinine, to look for the renal function, because these are excreted by the kidney. On the other hand, the sonographic contrast is safe in renal failure because it is excreted by the lungs. What is the composition of this? Basically, these are microbubbles. The sonographic contrast is microbubbles. What is the unique side effect with gadolinium? Remember NSF, that is nephrogenic systemic fibrosis. And where is barium contraindicated? Barium is contraindicated in any case of perforation. Barium cannot be given IV, it's only for the GIT, and even in GIT, it is contraindicated in perforation. So where is barium contraindicated? Barium is contraindicated in perforation. It's not to be given IV, it's given only in GIT conditions. Next one, what is this? This is a lead apron. Okay, this is a lead apron. And the lead apron, what is the minimum thickness recommendation according to AERB? That is the Indian guidelines. It is 0.25 millimeters minimum. Most common used is 0.5 mm. What is the maximum permissible dose in general public? It is 1 millisievert per year. In the occupational workers, in any particular year, the maximum is 30 millisieverts. It is 20 millisieverts per year, averaged over 5 consecutive years. In a pregnant female, to the embryo, the dose that is maximum to be given is 1 millisievert. For the pregnant female, it is 2 millisievert according to Indian guidelines. According to NCRP, the international guidelines, it is 5 millisieverts. Next one, what is this? This is a TLD badge, and how frequently do we monitor this equipment? So TLD, that is thermoluminescent dosimeter. This is a thermoluminescent dosimeter which measures the dose of radiation exposure in the occupational workers, and this is monitored every 3 months, that is every quarter of the year. It is monitored every 3 months. What is it made up of? Calcium sulfate dysprosium. It is made up of calcium sulfate dysprosium in India, or it could be lithium fluoride also. Next one. Now coming to the investigations identification. Let us identify these investigations. So what is the first one that we are seeing here? Identify. So this one here, is it CT or MRI? Whenever you want to differentiate it CT or MRI, always look at the bone cortex. You should always look at the bone cortex, not the bone marrow. In CT scan, the bone cortex is white. In MRI, the bone cortex is black. So what are we seeing here? Look at the bone cortex, the vertebra, the cortex is black. Look at the black lining. Look at the thin black lining, right? The bone cortex is black, and that is why this is MRI. So CT is out. Is it T1 weighted or T2 weighted MRI? So T2 weighted MRI, T2 has white water. So remember WW2, water white on T2. Now where is the water here? This is the CSF surrounding the spinal cord. That gray color is the spinal cord. Surrounding that is the CSF. So the CSF is white, and that is why the water is white, and that is why this is a T2 weighted MRI. Let's have a look at the next image. A and B. Here the bone cortex is black, so this is MRI. Here the bone cortex is white, so this is CT scan. Look at the bone cortex, it is white, so it is CT scan. CT or MR, the skull bone is white, so this is CT. Here, do not get confused by the white outline in the periphery. That's the fat in the scalp. This is not the bone. Where is the bone? Just outside the brain parenchyma, you can see the black line. So that is the MRI. The bone cortex is black. So always look for just outside the brain parenchyma to see for whether it is brain CT or it is brain MRI. Next one, how do you differentiate its non-contrast CT or contrast-enhanced CT? So contrast-enhanced CT, the contrast is given IV, so it goes into all the vessels, right? So the vessels will appear white on the contrast-enhanced CT. So look at this one, the white bone, both of these are CT scan. This is the aorta, this is the aorta. Look at the aorta appearing white, and that is why this is a contrast-enhanced CT. Aorta is grey, this is a non-contrast CT. Okay, compare it with the muscle car density. It is more white, it's a contrast-enhanced CT, which helps us in identification of the space-occupying lesions anywhere in the body, like liver metastasis, brain tumor, mediastinal mass. So, contrast is important for any space-occupying lesion. Next one, identify this MRI sequence, a previously asked question. So, whenever in MRI, you have those multiple black dots like this, think of the sequence which is the susceptibility weighted imaging, which is the most sensitive sequence to identify hemorrhage in MRI. And what do we see here is, this could be the other type of the image that can be given for susceptibility weighted imaging, where you see that the veins, they are appearing black. Okay, the vessels appearing black. So either the black areas or it could be the black veins. Now, in what case of a road traffic accident patient do you see those multiple areas of blooming, that is punctate hemorrhages in the brain? It is diffuse axonal injury. What is the history there? It's a road traffic accident patient with poor GCS, right? But the NCCT appears normal. NCCT could be normal or it could show the white hemorrhages. But the most sensitive sequence for that is SWI MRI. That is the investigation of choice. All other patients of head trauma, the investigation of choice is non-contrast CT. But here in diffuse axonal injury, it is SWI MRI, which will show the areas of blooming like this. Okay. Next one. Coming to the other MRI sequences, T1, T2 and flare. So remember that when the water is white, it's a T2 weighted MR. Here the water is white, water black. Look at the ventricles. So this is going to be T2, white water. T1, 1 is your first year MBBS subject anatomy. So when the anatomy is followed, that's a T1 weighted MRI. Anatomy followed means white matter is white, gray matter is gray. So look at the white matter here, the corpus callosum. The corpus callosum internal capsule is white. It's a T1 weighted MRI. When it is all black, it's a flare MRI. So water also black, white matter also black. You see the water is black, the white matter is black, right? This is going to be a flare MRI. Okay, so T1, T2 flare. What is this one here? The first sequence that you see here, water is black, the white matter is black, all black, this is flare. Here the water is black, the white matter black, this also looks like flare. But this is not a flare MRI, it looks like flare, but the difference is you do not see the surrounding bone and the scalp fat very well, which you see here in the flare MRI. So similar to flare, but without the skull or the scalp fat is the DWI MRI, which is the most sensitive sequence. What is the importance of DWI? It is the most sensitive sequence for acute infarct, right? It shows a restricted diffusion. So it is the earliest to pick up the acute infarct. CT scan can be normal in early infarct. This is what you are seeing here, an area of restricted diffusion, likely suggestive of acute infarct. Next one. Now coming to these orange color investigations. First one, when you see an ultrasound image, black and white, and then you have the orange ultrasound image, an orange colored ultrasound image, remember it is contrast enhanced ultrasound, where we use micro bubbles as the contrast, safe in renal failure. When you have the white bones, that's the CT scan with the orange areas, then it is PET CT. Asked many times previously, identify the investigation. If it was just black and white, then it would have been a CT scan. Here, because you see the orange color, then it's a PET CT. Okay, then it is a PET CT. Next one, coming to the angiographies, image A, B and C. What do we see here? Any angiography where the vessels are black, remember it is DSA. Black vessels can be only in DSA. Here you see the vessel, the internal carotid artery is black. So it is a DSA. It can be black or it can be white. But only in DSA, the vessel will be black. So digital subtraction angiography, which is done under fluoroscopy by arterial access, intra-arterial route. When you don't see the white bones, but you see the vessels, this is MR angio. Advantage can be done without a contrast. So we can do in renal failure patients also. Third, when you see the white bones and you see the white vessels, then it is CT angio. Okay, which is generally the investigation of choice for vascular pathologies like aneurysm dissection, because it is quick and it's easily available and it's non-invasive. DSA is generally the gold standard because it is invasive. Next one, another modality for vascular evaluation is the Doppler, which is basically a mode of ultrasound. So this also does not have radiation exposure because it is ultrasound. Color Doppler will show the color in the vessel. Along with that, if you see a graph like this, then it is called as spectral Doppler or a duplex Doppler. Okay, spectral Doppler, and you have the color Doppler. So color Doppler is generally the first investigation in the vascular pathologies where the vessel is accessible, like in peripheral vascular disease, where you have the history of the patient with intermittent claudication, ulcer on the toe. When you have these features, the first investigation is Doppler. Next one, what is this investigation? This is again the ultrasound, but in the ultrasound we see some colorful areas, but this is not in the vessel, right? It's not in the vessel, the colorful area. Also in the image, you see something which is mentioned on the scale, that is kilopascals, the unit of the strain, right? So when the strain is measured, this is called as elastography, which basically looks for the softness or the hardness of the lesion, that is the presence of the fibrosis. So it helps us identify that what is the chance that the lesion could be malignant. Commonly done for breast lesions, thyroid lesions, and in liver, basically to look for the development of cirrhosis. Next one, which of the following does not show the artifact shown in the image? What is the artifact shown in the image? So what do we see here is this black area behind this white area. So this black is the shadow. This is posterior acoustic shadowing. So which of these does not show posterior acoustic shadowing? Stones, bones, air or bile? So remember, it is bile which does not show the posterior acoustic shadowing. It is the highly reflective substances like stone. So what happens is when you are doing ultrasound, there's a stone, the sound comes and it's reflected back, right? Same as with the air, same as with the bone. They do not allow the sound to be transmitted through them. So that is why behind them what happens is there is no sound. So there is no image, no signal which is formed. So it appears black. So remember, stones, bones and air, they give posterior acoustic shadowing. Air, very, very important. Remember, is a bad conductor of sound. So for air pathologies, ultrasound is not that good. The most sensitive investigation for air containing pathologies is CT scan. Now coming to bile. Bile is fluid and fluid appears black on ultrasound by itself. Fluid is anechoic. It is black on ultrasound, right? Stones, bones and air by themselves will appear white. That is echogenic or hyperechoic. Behind them you would see the shadow like you are seeing in this case. So look at the stone itself is appearing white, but behind that is the shadow, right? So that is why for gallstones, the investigation of choice is ultrasound. We identify by posterior acoustic shadowing. Now what is posterior acoustic enhancement? First we saw posterior acoustic shadowing. What gives posterior acoustic enhancement is a cystic lesion. If behind a lesion, you see that the area is very white as compared to the rest of the area, then it is called as posterior acoustic enhancement. Enhancement means white. So it helps us identify that the lesion is a cystic lesion and not a solid lesion. Next one, identifying this GI contrast studies. First one, where you see the stomach, you see all the bowel loops, the small bowel loops completely. This is barium meal follow through, where it is basically done for the evaluation of the small intestine. And here you see the feathery appearance of the jejunum. This one, where you see the bowel loops, but along with that, you see some tube coming in. So that is going to be small bowel enema, that is enteroclysis. So in BMFT, the barium is given orally. Here we put an NJ tube and then we put the contrast. So this is enteroclysis, where you would have the presence of the tube also. Third, where you see that there is no barium in the small bowel loops in the stomach, the barium has actually come transrectally. So that means this is for the colon, the large bowel. This is barium enema, which is basically for the colon, which is identified by these hostrations. Okay, which is identified by hostrations. Next one, looking at the biliary tract, the investigations there. First one, where you see the endoscope. This is going to be ERCP, where you see the endoscope, the CBD and the pancreatic duct also. It's basically a contrast X-ray. You can see the white bones behind. So it has radiation exposure. Second one, where you see the bile duct and the pancreatic duct, but no endoscope, that is going to be MRCP, which is actually done in MRI, a T2 weighted MRI to see the white fluid, and that is why it has no radiation exposure. Next one, where you see that there is this T sort of tube in the bile duct coming from the skin, right? We have clamped it. This is a T-tube cholangiogram. Okay, this is a T-tube cholangiogram. Next one, when you see that the catheter is coming in, not into the main CBD, but into one of the peripheral radicals, then it is called as PTC. That is percutaneous transhepatic cholangiogram, right? So it's not in the main CBD, but in the peripheral radical. And this one, which you see the areas, that is the gallbladder, the CBD, showing those black areas, the anatomy is not very well seen. This is a nuclear scan for the biliary tract, that is the HIDA scan, right? So HIDA scan is basically the nuclear scan for the biliary tract, and it helps us in evaluating the patency of the biliary tree. In biliary atresia, you will not see this uptake. Second, it also helps us in evaluating the leak, right? So basically, it helps us in ruling out biliary atresia. It is the most sensitive to identify the bile leak identification after surgery, okay, in any patient. So this is HIDA scan for the biliary tract. Next one, now coming to the urinary tract, the contrast X-rays, the dye studies, IVP, RGP, MCU and the RGO. Now when I say IVP, RGP, the P tells me the pylo part, that is the kidney ka pelvis wala part will be seen. So when I see the kidney, then I think of a pylogram. When along with the pylogram, I see a cannula here at the ureteric orifice, then it's a retrograde. That means the contrast was pushed in a retrograde manner. So this is RGP, retrograde pylogram. This is IVP, intravenous. The contrast is given intravenous, excreted by the kidney. We take the X-ray images, right? So this is IVP, where you would see both the kidneys if they are normal functioning. And this is RGP, where you have one kidney at the time. Next one, where you have the urinary bladder distended with contrast. So you are seeing the cysto part. You are also seeing the urethra part. The urethra is also containing the contrast. So this is a cystourethrogram. The bladder is distended. That means the patient is micturating. This is micturating cystourethrogram, also called as voiding cystourethrogram. Okay, also called as voiding cystourethrogram. Next one, where we see that the contrast is only in the urethra. The cannulation is done at the external urethral meatus. This is a RGU. that is retrograde ureterogram, also called as ASU, that is ascending ureterogram, right, which is the investigation of choice for urethral rupture, urethral injury, which is denoted by the blood at the meatus, right? In that case, the investigation that we do is RGU. Okay, we do RGU. So these are the contrast X-rays for the urinary tract. Now, in a patient, if you do MCU and you see the contrast in the kidney or in the ureter, then it is suggestive of vesico-ureteric reflux. So vesico-ureteric reflux, if in MCU, the contrast is present in ureter or in kidney, then it is suggestive of reflux, because when the patient is micturating, the contrast should not go back. If it is going back, that means there's a reflux. Okay, there's a reflux. And also remember that MCU is the investigation of choice for which two conditions? VUR and PUV. Okay, the VU and the UV containing pathologies, VUR and PUV, that is posterior urethral valve. Now coming to the gynecovala investigations, this is the X-ray with the contrast in the uterus, the fallopian tubes. This is a contrast X-ray, that is hysterosalpingogram, best done at around day 9 of the menstrual cycle. The HSG image in the exam can also come like this, with the uterus appearing black, because remember that these investigations, the contrast X-rays, are done under fluoroscopy. So similar to DSA, where the vessel appears black, this can also appear black. This is also HSG. Next one, when in the ultrasound, right, this is the ultrasound, this is the endometrial cavity. You are seeing that there is black fluid there. So the endometrial cavity has been distended with the saline. This is called as sonohysterogram, right? Sono HSG or saline infusion sonography, where we put the saline, distend the endometrial cavity. Basically, it's the best investigation to help us confirm the endometrial polyp. It is the best investigation to help us confirm the endometrial polyp. Going to next one, what investigation is this that we are seeing here? This is an X-ray, but in the X-ray, we are seeing the contrast in the spine wala region. So this is X-ray myelogram, right? X-ray myelogram, which used to be done pehle when there was no evolution of MRI. Next one, where you see the white bone, and along with that, you see this contrast surrounding the spinal cord. There's that white contrast. So this is the CT scan along with the contrast surrounding the cord. This is CT myelogram. Okay, this is CT myelogram. Next one, where you see the contrast here in the sulcal space, right? And this is the CT cisternogram, which is similar to myelogram. But CT cisternogram, we allow the contrast to come into the cisternal spaces, the sulcal spaces, and we look then with the prone position, we look for the CSF leak. Okay, so CT cisternogram is done for CSF leak. Next one, now we are going to discuss the normal anatomy. So now we are going to see the important radio anatomy integrated images. First one, identify the label structure. So let's have a look at this labeled image first. This is a MRI with the black bone, T1 weighted MRI with the white matter white. What do we see? This is a frontal horn. Adjacent to that, the basal ganglia that we have is the caudate. The lateral ventricles, they open into the third ventricle. So slit-like in the midline, this is the third ventricle. Adjacent to the third ventricle, the two structures that we have is the thalamus. Now we have the internal capsule. Lateral to that, we have the globus pallidus, and we have the putamen, which together form the lentiform nucleus. And lateral to lentiform nucleus, this part of the brain is the insula. So looking at this image now, the labeled structure here is the thalamus, which is adjacent to the third ventricle. Frontal horn ke baaju mein is the caudate, and this is the insula, and this is where we have the globus pallidus. The medial is the globus pallidus, the lateral is the putamen, together forming the lentiform nucleus. Now going to the next one, sagittal MRI of the brain with the black bone. This is the corpus callosum. This is the fornix here, right? The corpus callosum, the white matter related to corpus callosum, that's the fornix. There we have the lateral ventricle. This label structure here is the thalamus. Look at the brainstem, the midbrain, the pons and the medulla. The pons is bulging like this. In front of the midbrain, the small rounded structure that we have is mammillary body, which is commonly involved in Wernicke's encephalopathy. The next that we have, this triangular structure here behind the pons is the fourth ventricle, and behind that is the cerebellum. Okay, that's the cerebellum. This is the pituitary gland with the posterior pituitary bright spot there, and below that is the sphenoid sinus. This is the optic chiasma, the white matter tract related to pituitary, and that is why a pituitary lesion compressing the optic chiasma can cause bitemporal hemianopia. The visual field defect is bitemporal hemianopia. Next one, what is the label structure here? Now we have seen everything. So this is the cerebellum. Okay, this is the cerebellum that we are seeing here. Next one, what is this structure here? This is the midbrain on this MRI brain. Midbrain has this heart shape or the Mickey Mouse shape that we are seeing there. Okay. Next one, in this MR angio, what is the labeled vessel here? The tortuous vessel supplying the brain, that is the internal carotid artery. Look at its terminal branches. It gives the middle cerebral artery going laterally, and it has the anterior cerebral artery going anteriorly. The posterior circulation, these are the two vertebral artery joining to form the basilar, and it gives the terminal branch, which is the posterior cerebral artery. And this is where we have the circle of Willis. Next one here, identify the labeled vessel. So one step ahead in the angio, these are the two vertebral arteries joining to form basilar, and this is a branch coming from the basilar. Now from the basilar, the terminal is the posterior cerebral artery that we have here. Below the posterior cerebral artery, the second last, SS, second last is SS. This is the superior cerebellar artery. Coming from the inferior part of basilar is the inferior cerebellar artery, which is anterior inferior. Posterior inferior cerebellar artery, it comes from the vertebral artery that gives the pica, the posterior inferior. So this is the ICA coming from inferior basilar. So remember that basilar artery, the trick to remember, gives the cerebellar arteries, which is A and S, that is ICA and SCA. Okay, those are the cerebellar arteries from the basilar. Next one, coming to the normal chest radiograph, the right heart border, this is the right atrium predominantly. Right ventricle does not form the right heart border. Left side is the left ventricle. This one here is the aortic arch forming the aortic knuckle. At the hilum, the predominant structure that we have is the pulmonary artery. This angle here is the cardiophrenic angle between the heart and the diaphragm. The angle here, which is actually cut in the image, is the costophrenic angle. Okay, the costophrenic angle, which is blunted in pleural effusion. The rib which is horizontal here, that is the posterior rib. The rib which is more oblique, right? You have the posterior end of the rib, then it comes oblique. Costal cartilage will not be seen here. The more oblique is the anterior rib, asked in the recent FMG exam. So posterior rib horizontal, anterior rib oblique. In the trachea, this is the black air containing trachea in the center. The bones that you see in the center, that is the spinous process of the vertebra. Okay, that's the spinous process. Next one, identify the structure here. So the three vessels in the mediastinum from right side to left side, they are arranged as SAP. That is the superior vena cava, the ascending aorta and the pulmonary artery. So from right to left, this is the SAP. So superior vena cava, ascending aorta, pulmonary artery, dividing into the right and the left. Behind that, the air containing structures that we have, these are the bronchus, the right bronchus and the left bronchus. And left bronchus ke piche yahan pe we have the descending aorta. To the left of the vertebra is the descending aorta. So this label structure here is superior vena cava. This we have already seen. What is going to be this structure now? Pulmonary artery. In this image, in the center, the black air containing, that's the trachea. To the left of the trachea is the arching structure, which is the arch of aorta. To the right of the aorta, SAP that we have is the superior vena cava. So this is the superior vena cava. This is the arch of aorta. And this bone here behind the ribs, behind the thoracic cage, the bone that we have is the scapula. Okay, that's the scapula there. Coming to identification of the heart chambers, anterior most, this is the sternum. Now behind the sternum, the anterior most chamber that we have is the right ventricle. Right ventricle, now this is the axis of the heart. Whatever is to our left side is actually the patient's right. So this is the right ventricle. Adjacent to that will be the right atrium. Adjacent to right ventricle on the left will be the left ventricle. Adjacent to that will be the left atrium. So which is the posterior most chamber of the heart? Close to the vertebra. First one is the left atrium, is the posterior most chamber, the enlargement of which can cause esophageal compression. Okay, the enlargement of which can cause esophageal compression. We have the esophagus behind the left atrium. Next one, in the abdomen, differentiating the small bowel from the large bowel. Small bowel has complete rings, that is called as volvulae conniventus. Large bowel has incomplete projections, which are called as rostrations. Small bowel is more in the center of the abdomen. Large bowel is in the periphery of the abdomen. This is how we differentiate the two. Identify the labeled part. This is the CT abdomen. CT abdomen vertebra ke aage we have the aorta. To the right of the aorta, the vessel that we have, the one which is asked here, this is going to be IVC. Where is the portal vein? IVC ke aage is where we have the portal vein, right? Behind the pancreas, IVC ke aage is the portal vein. This fluid density structure, this is the gallbladder. Okay, this is the gallbladder. So the labeled part here is basically the IVC to the right of the aorta. Okay, to the right of the aorta. Next one, in the CT abdomen, again revising, this is the aorta, this is the IVC, this is where would be the portal vein. So aorta, IVC, portal vein, and we have the gallbladder here. This is the pancreas going towards the spleen. Behind the pancreas is the splenic vessel. Okay, that's the splenic vessel. Kienbock's disease affects which bone? Now, Kienbock's is osteochondritis of lunate. Remember alphabetically GHIJKL. Kienbock's K ke baad aata hai L. It affects the lunate. Now, where is the lunate? She looks too pretty. Try to catch her. So, adjacent to scaphoid. So, she looks too pretty is the proximal row of carpal bones. Try to catch her is the distal row. This is from the radius to the ulna. So, radius ulna, radius wider, ulna thinner. So, we start from here. She looks too pretty. Try to catch her. So, this is the lunate bone labeled 2. So, the answer will be 2. Right? That is the Kienbock's. First bone to ossify capitate, last bone to ossify pisiform. Coming to tarsal bones, where is the navicular? So remember TT, tibia ke side on the medial side is the talus. So calcaneum on the lateral side. CC, calcaneum ke aage we have the cuboid. Talus ke aage we have the navicular. So look at this one. What do we have here? The one which forms the ankle joint articulating with tibia is the talus. The one which forms the heel bone is the calcaneum. Calcaneum forms the heel bone. In front of the talus, this is where we have the navicular. Okay, that is where we have the navicular. Look at this image again. This is the tibia. This is the fibula. Tibia ke side mein. This is where we will have talus. Talus ke aage is where we have the navicular. Talus ke side mein the heel bone is the calcaneum and calcaneum ke aage is the cuboid, and then we have the cuneiforms. Okay. In this image here, this is where on the medial side, the nerve shape, the boat shape is the navicular. Navicular is nerve shape. And this is where we have the talus. We have the calcaneum. Calcaneum ke aage, CC, we have the cuboid. Talus is on the tibia side and the navicular is on the medial side in front of the talus. Identify the label part. So in this early pregnancy, what does this represent? So the outermost one, inside which everything else develops, is the gestational sac. The small rounded structure within the gestational sac is the yolk sac. This is the fetal pole and the membrane surrounding the fetal pole is the amnion, right? So gestational sac, yolk sac, amnion, and this is the fetal pole. So this one here is the yolk sac, which is the first definitive sign of intrauterine pregnancy. I'm talking about definitive sign. Gestational sac is the first sign of intrauterine pregnancy. But there could be a pseudo-gestational sac also. That is why if the question asks first definitive sign, then it's going to be the yolk sac. Now, the next segment that we are going to discuss is neuroradiology. So now we are going to discuss about neuroradiology. So which of the following might have led to the given pathology? What do we see here? This is a CD scan with the white bone. And we see those white areas in the sulcal spaces. What is white on non-contrast CT? is either acute hemorrhage or calcification. So this is the acute hemorrhage in the sulcal spaces. Sulcal spaces contain the CSF. That means it is the subarachnoid space. So this is subarachnoid hemorrhage. Now what leads to subarachnoid hemorrhage? Rupture of middle meningeal artery leads to EDH, extradural hemorrhage. Aneurysm rupture, it's what leads to subarachnoid hemorrhage. Hypertension leads to intraparenchymal hemorrhage. Cortical bridging vein rupture leads to subdural hemorrhage. Most common cause of subarachnoid hemorrhage is trauma. Okay, most common cause is trauma. So this is subarachnoid hemorrhage. Look at the various hemorrhages here, all of them acute because they are hyperdense. So remember that acute hemorrhage is hyperdense on non-contrast CT. The first one, which has this biconvex shape, idly shape, idly shape is EDH. It does not cross the sutures. Second, which has this crescent shape or sickle shape. Sickle shape, S for S, is the SDH. It crosses the sutures. Third one in the sulcal spaces, in the cisterns, subarachnoid space. This is subarachnoid hemorrhage. The patient presents with thunderclap headache. If you see subarachnoid hemorrhage, what is the next investigation to be done? CT angio to look for aneurysm which has ruptured, which is the other aneurysm which can rupture. To look for that, we do CT angio. In which of these do we see the lucid interval? Remember, lucid is like ED. It is seen in EDH. Lucid interval is seen in EDH. Next one, how do you differentiate in a patient of stroke, focal neurological deficit, whether it's because of infarct or it's because of hemorrhage? Why is it important? Because the management depends on that. So remember that the hemorrhage is going to be hyperdense. Hemorrhagic stroke would be hyperdense. Ischemic stroke, infarct would be hypodense. So infarct is hypodense, hemorrhage is hyperdense, infarct is hypodense, that means dark, and it is confined to the vascular territory. Like this is the right MCA infarct that we are seeing. For infarct, the most sensitive is the diffusion weighted imaging. First always is non-contrast CT in a patient of stroke. Then if you don't see, then you can do the diffusion weighted imaging. Next one. This is a 60-year-old male having lymphoma, now having fever altered sensorium. What is the causative agent? Asked in this year's NEET PG, there were two questions. So what do we see here? There is this abnormal signal intensity in the temporal lobe bilaterally, the basifrontal lobe, the temporal lobe. So whenever there is temporal lobe involvement and the infectious agent is asked, it is always HSV. Herpes simplex virus affects the temporal lobe. Remember that. Next one, let's have a look at the other infections also, where you see those multiple white dots scattered throughout the brain. This is the starry sky appearance of neurocysticercosis, the calcified NCC. The next image here that we see here, where you see the conglomerate lesions, where you see hydrocephalus. So conglomerate lesions along with hydrocephalus, along with the meningitis, the basal exudates which are enhancing, suggestive of meningitis, and in the MR spectroscopy. This is the MR spectroscopy showing this peak is the lipid peak. All these features tell you that this is TB. Remember, TB bacterium has mycolipid. So it gives the lipid peak, meningitis, hydrocephalus, and the conglomerate lesion. Very, very important. What do you see here is the periventricular calcification. Remember, the periventricular calcification is seen with cytomegalovirus, where the baby can have SNHL is a common presentation there, complication there. And what else do we see is the owl's eye inclusions with CMV, cytomegalovirus. What is this one here? Here we see that perpendicular to the ventricle, there are these demyelinating plaques like the fingers. These are called as Dawson fingers. Dawson fingers are seen in multiple sclerosis, a demyelinating condition. Investigation of choice, contrast enhanced MRI. In the axial MRI also, perpendicular to the ventricle, we see those demyelinating lesions. Next one, coming to the pituitary lesions that we have here. So look at this image and look at this image. In the first image, in the midline, in the center, So this is a lesion in the center having calcification. If I tell you that this is a child, C, think of another C. This is craniopharyngioma. In a child, calcification, and you have center mein, it is craniopharyngioma. So craniopharyngioma is a suprasellar lesion from the Redcase cleft pouch remnants. So what do we see here? Look at the MRI. This is the pituitary. Superior to that is this lesion, suprasellar craniopharyngioma. So this is craniopharyngioma. On the other hand, where you see that the sella is widened, there is this figure of 8 sign, then it is pituitary adenoma. So when you have sella widening with figure of 8 sign, it's pituitary adenoma. Adenoma from the pituitary goes out, right? So it has that figure of 8 appearance. Okay, the figure of 8 appearance. Next one, what are we seeing here? So what are we seeing here is basically this molar tooth appearance of the midbrain because of the elongated superior cerebellar peduncles. So look at the molar tooth appearance of the midbrain, and this is seen in Joubert syndrome. Okay, Joubert syndrome has the molar tooth appearance. Coming to some other important signs in neuroradiology, the first one, which is the eye of tiger sign. So remember, tiger is scary like Halloween. So it is seen in Hallow-Warden-Spatz disease. So eye of tiger sign is seen in Hallow-Warden-Spatz disease. Where is the eye of tiger? This is where we are seeing the eye of tiger appearance. Black ke andar, the white dot in the globus pallidus. Next one, this is the hummingbird. Okay, so we are talking about hummingbird sign. Bird goes supra, bird flies up supra. Remember, it is seen in supranuclear palsy, progressive supranuclear palsy, where we have midbrain atrophy. So look at the midbrain atrophy, the bulging pons, that gives the hummingbird sign. Next one, Wilson's has a face like giant panda. Remember, a person named Wilson has a face like giant panda. So this is the face of giant panda sign, which is seen in Wilson's, affecting the midbrain. Along with that, in Wilson's, we have the KF rings in the cornea. Next one, this is the hot cross bun, not the vada pav, right? This is the hot cross bun sign, which is seen in the pons here. You see that hot cross bun. So like a cross sign, this is seen in multi-system atrophy. The hot cross bun sign is seen in multi-system atrophy. Going to the next one, the ventricle enlargement, but it's not symmetrical aage piche. What do we see in this image? The frontal horns are more dilated. In this image, the posterior horns are more dilated. So when the frontal horns are more dilated, it is called as boxcar ventricle, which is seen in Huntington's chorea, right? Remember, chorea, C for C, is because of caudate atrophy, and caudate atrophy leads to the enlargement of the frontal horn. Adjacent to frontal horn is caudate. Caudate atrophies, frontal horn dilates, boxcar ventricle. Here, when the posterior horns are more dilated, colpocephaly. This is called as colpocephaly when the posterior horns are dilated, which is seen in corpus callosum agenesis. Corpus callosum agenesis. This is called as racing car sign. When the posterior horns are dilated, the racing car has the piche ke wheels more large. So this is the racing car, is corpus callosum agenesis. Boxcar is the Huntington's chorea. What do you think is the diagnosis here? Which tumor do you think is this? Now, since this tumor is crossing the midline, involving both the sides, basically involving the corpus callosum, it has the central necrosis. That is why this is glioblastoma. So glioblastoma commonly involves the corpus callosum. That means it crosses the midline. It has the central necrosis because it's a high-grade tumor. So these features tell you that this is glioblastoma. This is also called as butterfly glioma. Okay, it is also called as butterfly glioma. Next one, what tumor do you think is this? So this tumor, which is homogeneously enhancing, it has this tail-like extension, the tail-like extension, which is called as dural tail sign. So remember, dura is meninges, dural tail sign is seen in meningioma, okay, which on histopath shows samoma bodies. So homogeneously enhancing, dural tail, think of meningioma. It can also show calcification and hyperostosis of the bone. Next one, what are we seeing here? So this is a cystic lesion, not enhancing, cystic lesion, but with a enhancing, just a nodule is enhancing along the wall. So we have a cystic lesion with an enhancing mural nodule, which is seen with hemangioblastoma. Okay, which is seen with hemangioblastoma is a cystic lesion with enhancing mural nodule. This is if the patient is adult. Same findings if you see in a child, cystic lesion with enhancing mural nodule. Then you should think of pilocytic astrocytoma. It has similar appearance. And where is this hemangioblastoma associated with which syndrome? It is associated with von Hippel-Lindau syndrome. Okay, VHL. Now, since we spoke about VHL, let's have a look at the other neurocutaneous syndromes also, where you see this calcification along the ependyma, the lining of the ventricle, subependymal nodules, which can be calcified. These are hallmark of tuberous sclerosis, right? Which can have cardiac rhabdomyomas, lymphangioliomatosis in the lung, and renal angiomyolipomas. So calcified subependymal nodules, tuberous sclerosis, this can enlarge and form a tumor which is SEGA. When you have this calcification in the brain following the gyri, calcification like this is called as tram track calcification. Tram track calcification is seen in Sturge-Weber syndrome. Okay, it is seen in Sturge-Weber syndrome. Remember SSS for Sturge-Weber. It has a stain, port wine stain. It has seizures as a clinical feature, and it is sporadic. It is not inherited, it is sporadic. So, tram track calcification, Sturge-Weber syndrome. Where you see this ice cream cone appearance, this is vestibular schwannoma, showing the ice cream cone appearance. Bilateral vestibular schwannoma is diagnostic of NF2. Remember, bilateral 2, NF2, chromosome number 22. Okay, this is bilateral vestibular schwannoma. Straight ahead, it becomes NF2. We saw tram track calcification. Let's have a look at the other calcification. This is the bracket jaisa calcification. Okay, this is called as bracket calcification, which is seen in corpus callosum lipoma. Lipoma fat calcifies. Okay, so midline के आजू बाजू bracket calcification, corpus callosum lipoma. Popcorn jaisa appearance, popcorn calcification is seen in cavernoma. Okay, it is seen in cavernoma in the brain. Next one, what is this? If I tell you that this is a neonate with a classical history of hydrocephalus and heart failure. The history is enough to make a diagnosis of vein of Galen aneurysmal malformation. Right, classically it will show this dilated vessel draining into the straight sinus. This is the vein of Galen malformation, which actually is the AV fistulas draining into the precursor of vein of Galen. Okay, so this is vein of Galen, aneurysmal malformation. Classical image, sagittal in the midline, you would see this structure. Next one, this investigation is DSA because of the black vessel. You see the contrast going out of the vessel like a puff of smoke. So this is called as puff of smoke appearance, which is seen in Moya-Moya disease. Okay, the puff of smoke appearance is seen in Moya-Moya disease. Next one, coming to the various MT signs, the MT delta, the MT cella, the MT theta sign. So this one here where you see a triangle which is empty, triangle is a delta. Empty matlab it's not containing contrast, it's not getting filled with contrast because it is thrombosed. So this is the location in the midline behind, that's the location of superior sagittal sinus. So this is superior sagittal sinus thrombosis, showing the empty delta sign because it is not getting filled with contrast because of the thrombosis. This one here, the empty theca sign. So what do we see here is, look at the thecal sac just containing the CSF, not containing any nerve roots. Look at the normal one. What do we see with the normal thecal sac? It contains this black nerve roots. So this empty theca sign is seen in arachnoiditis. The arachnoid inflammation pulls the nerve roots towards itself, clumping the nerve roots. So the thecal sac just has the CSF. So this is arachnoiditis, empty theca sac sign. What do you see here? Look at the sella turcica, the pituitary gland, it's hardly seen. So it is like empty sella. What is the empty sella sign seen in? It is seen in raised ICT, intracranial hypertension. The high intracranial pressure, it goes into the sella, the CSF goes in, right? And that gives the empty sella sign. It is seen in intracranial hypertension. Okay, empty sella sign, right? Coming to this one, what are we seeing here? On this MRI, look at the temporal horn. The temporal horn here is more dilated as compared to this one, asymmetric dilatation. So when you have this asymmetric temporal horn dilatation, you should think of hippocampal atrophy, which is seen in mesial temporal sclerosis. Mesial temporal sclerosis, which causes complex partial seizures, right? So this is where temporal horn ke aage you have amygdala. Behind that you have the hippocampus. The atrophy leads to the temporal horn dilatation. Look at the schematic coronal image here. Below the temporal horn here, this is the hippocampus. Hippocampus atrophied here, smaller. The temporal horn becomes prominent. So asymmetrical prominence of the temporal horn, think of hippocampal atrophy. Best for measuring the hippocampus volume is MRI, coronal, oblique. Oblique coronal section is the best to measure the hippocampus volume. Okay, to measure the hippocampus volume, right? So yes, that was about neuroradiology, focusing on the most important images. The next system that we would see is head and neck. Hello friends, so now we are going to learn the important images in head and neck radiology, basically integrating ENT ophthalm with radiology. And from this section particularly, we have been seeing a lot of questions in the recent exams. So all the images, like in detail, have been covered in the main videos and rapid revision. Here in Snapshot, we are focusing on the most important and the frequently asked images. So first one, what do we have here? The X-ray views for the paranasal sinuses. And what is the first image showing? This X-ray view. What is this X-ray view? This is the Waters view. This is Waters view. Why do I call it Waters view? Because we can see the maxillary sinus well here. Okay, we can see the maxillary sinus well, right? So Waters view is also called as the occipitomental view. It is also called as occipitomental view. What is Pierre's view? Remember, Pierre's view is Waters view open mouth. Waters view with open mouth, which additionally helps us to visualize the sphenoid sinus as well. That is Waters view open mouth, Pierre's view. The next that we have here is, what X-ray view is this? One of the FMG exam question. This is the Cardwell views. Okay, this is the Cardwell view, which is the best view for visualization of frontal sinus. And how do I know this is Cardwell? Because I don't see the maxillary sinus well here. There's a bone overlapping the maxillary sinus. So what is it best for? The frontal sinus. So remember, this is Cardwell view for frontal sinus. Next one, very, very important signs. What are we seeing here? The thumb sign and the steeple sign. The thumb sign is seen in, so look at the appearance of the epiglottis here. The epiglottis looks like a thumb. It's a thickened, inflamed epiglottis. So this is seen in acute epiglottitis. Okay, this is a feature of acute epiglottitis, which shows the thumb-like thickening. This is the steeple sign asked in the recent NEET PG and the previous exams as well, many times. So steeple sign is seen in croup, also called as laryngotracheobronchitis. So the inflammation leads to the narrowing of the airways, and that is how it appears pointed, and that is what we are seeing here. This is the narrowing of the airways. Now a trick to identify this. To visualize the thumb sign, you will need a lateral view of the X-ray neck. To visualize the steeple sign, you would need a frontal view of the X-ray neck. So lateral diya hai, so then you should think of the thumb sign and not the steeple sign. Going to next one, whether this coin is in trachea or the coin is in esophagus. So the trick to remember that is, when you write esophagus, write it with O. So remember that esophagus, the coin in the esophagus is circular in the AP view and it is slit-like in the lateral view. It is slit-like in the lateral view. Opposite is with the coin in the trachea. When I write the trachea, the T, the vertical line tells me that it is slit-like in the AP view and it is circular in the lateral view. So have a look at this one. How is the coin in the AP view? It is circular, so it is the coin in the esophagus. You can also see here in the lateral view, the air column of the trachea, and behind that is where we have the coin. So it is in the esophagus. Okay, so this coin here basically is in the esophagus. Next one, this coin is, because in the frontal view, the coin is slit-like, in the lateral view, it is circular. So this is going to be the coin in the trachea. Remember trachea ka T, the vertical, the slit-like, right? Next, what do we have here is, this is one of the recent FMG exam questions. An important background history given here is, this patient is a trumpet blower and now presents with a swelling in the neck. Trumpet blower, very, very important feature telling you that there are chances of developing laryngocele. And look at the image here, the swelling here when you've done a radiograph. The swelling here is containing air because it's black, and this is the swelling communicating with the larynx there, and it is containing air. The air-filled swelling communicating with the larynx, that is laryngocele. Okay, so the diagnosis is laryngocele. Next one. A patient presenting with epistaxis was diagnosed with JNA. What is the sign demonstrated? So what sign are we seeing here? So look at this. This is the CT scan. This is the maxillary sinus. The maxillary sinus. Here with this maxillary sinus, you can see it's appearing small because there is something behind the maxillary sinus which is pushing the posterior wall ahead. That mass, something behind, is the JNA. So this mass here is causing the anterior bowing of the posterior wall of the maxillary sinus. So which wall of the maxillary sinus is bowing? The behind wala wall, that is the posterior wall. In which direction the bowing is happening? In the anterior direction. So this is the anterior bowing of the posterior wall of maxillary sinus, and this is called as what sign? This is called as the Holman-Miller sign. Okay, so classically the patient's age generally in JNA, it would be an adolescent male presenting with recurrent epistaxis, right? So this is Holman-Miller sign. Where do you see the Phelps sign? Phelps sign is seen in glomus tumor, glomus jugulare. Okay. Next one. What sign are we seeing here? First, have a look at the radiograph. There is something coming here from the floor of the orbit. So basically, there is a fracture of the floor of the orbit, which is called as blowout fracture. And through that fracture, the fat, the muscle, the inferior rectus muscle can herniate out. That is called as teardrop sign. Okay, that is called as teardrop sign. Look at the CT as well. The fracture here in the inferior wall, and through that the contents herniating out. That is the teardrop sign of the fractured floor of orbit. That is blowout fracture. Next one. What investigation is this? This is a DSA because the vessel is black, right? And what are we seeing here? This is the common carotid artery with its branches here, the ECA and the ICA, which are getting separated away because of some mass here. You can see the vascularity, the blood supply in that mass. So at the bifurcation of the common carotid, we have the carotid body. So basically this is showing carotid body tumor, also called as chemodectoma. Carotid body tumor, chemodectoma, causing the splaying of the ICA and the ECA, which is called as what sign? Which is called as the Liar's sign. Okay, that is the Liar's sign. Next one. Now, if I tell you that this is a patient of CSOM, that is chronic separative otitis media, what complication of CSOM are you seeing in this patient? Previous NEET PG question. Is it a temporal lobe abscess? Is it a cerebellar abscess? So, where is the lesion located? This is the temporal lobe. This is the temporal lobe of the brain, the inferior most lobe that we are seeing, and this is where the cerebellum is. Right, so if it would have been a cerebellar abscess, it would have been in the cerebellum. This is in the temporal lobe, ring enhancing lesion. So this is temporal lobe abscess. Right, now abscess classically shows this ring enhancement. It's a ring enhancing lesion because in the center it has pus, so that pus will not enhance. So this is a ring enhancing lesion. If you do MRI in a patient of brain abscess, what does it show? It shows central restricted diffusion. The thick pus in the center shows the central restricted diffusion, with peripheral enhancement. Okay, with peripheral enhancement, that is what we see with brain abscess. Going to the next one, this is MRI and showing the two optic tumors, optic glioma, optic meningioma. How do we differentiate the two? Now, optic glioma is from the nerve itself, so the nerve will enlarge. There would be fusiform swelling of the nerve. Optic meningioma is the meninges wala, so adjacent to the nerve, the meninges getting thickened, so 1-2 meninges surrounding the optic nerve, that gives the tram track sign. So look at the image here, what are we seeing? Look at the thick enhancement surrounding the optic nerve in the center. This is where the optic nerve would be. Going through the apex of the orbit would be the optic nerve, right? So this is the tram track sign that we are seeing here. So this is suggestive of optic nerve meningioma. The tram track appearance is seen in optic nerve meningioma. And optic nerve meningioma is associated with NF2. This one here, look at the thickening of the nerve. It is the fusiform swelling of the nerve itself. So this one is optic nerve glioma. Optic nerve glioma is associated with NF1. Okay, that is associated with NF1. So that was about the head and neck part of the snapshot. Now going to the chest, the thoracic radiology, where we would see the respiratory system and the cardiovascular system. So starting with the respiratory system, first one, coming to a normal anatomical variant. What is this radiograph showing? What are we seeing here? So in the right upper lobe, you are seeing this linear structure like this. This is called as azygous fissure because of the azygous vein which drains into the superior vena cava. So this is what is the azygous fissure and forming this lobe which is the azygous lobe. So azygous fissure with the azygous lobe which is a normal anatomical variant. Next one, a 20-year-old man got stabbed last night and presents with chest pain and dyspnea. What is the diagnosis? Very, very important. So what do we see in this radiograph is, this is the jet black appearance without any vascular markings, suggestive of pneumothorax. There is the visceral pleural line. So when you have air without the vascular markings, that is air outside the lung, and that is when it would be pneumothorax. So this image is basically showing this right-sided pneumothorax with the collapsed lung. So the diagnosis here is right pneumothorax. Now, how do you differentiate pneumothorax from pleural effusion and from hydropneumothorax? Now remember that pneumo is air, so it would be black. Pleural effusion is water, so it would not be black. How do you differentiate pleural effusion from hydropneumothorax? Pleural effusion, the upper margin of the fluid is never horizontal. In hydropneumothorax, that is the air and the water both, the air fluid level appears horizontal. In pleural effusion, it is not horizontal. So based on this, whenever you see this horizontal level, this is the water part below, there is blunting of the angle. This is hydropneumothorax, which shows the horizontal level, okay, which shows the horizontal level. This one here where you see the LSS curve, this is the pleural effusion, the blunting of the angle with the LSS curve, not the horizontal level, it's the pleural effusion. And this one here, the entire air surrounding this lung, this is the left-sided pneumothorax, okay, that's the left pneumothorax. So remember that for pleural effusion, the most sensitive investigation is ultrasound. For fluid, it is ultrasound. Now, what do you think is this image showing? This is a CT scan, the lung window, and this is the visceral pleural line. Surrounding that is the jet black air without any vascular markings. So this one here basically is the pneumothorax, right side or left side? Your left, that means the patient's right side. This is the right-sided pneumothorax. The most sensitive investigation for it is CT scan. Look at how the normal lung has the vascular markings, the vessels going into it. The pneumothorax is outside the lung, so it does not have the vascular markings. Next one, what do you see in pneumothorax in ultrasound? So now we do E-fast in a patient of trauma. The E is the extended fast, basically, which is extended to include the thoracic cavity. It is extended to include the thoracic cavity. And in E-fast, the M mode of ultrasound, pneumothorax shows this barcode or stratosphere sign, while the normal lung shows the seashore sign. So what are we seeing here? What is the seashore? So basically in the lower part of the image, which shows the lung movement, you would see the granular appearance because of the movement of the lung like you are seeing here. Right, there is this pleural line, the white pleural line. Above that is this chest valca layer, which is flat. This is the pleural line, and below that is the lung movement. This is the seashore. Okay, the granular appearance, the seashore sign. If there is pneumothorax, so above the lung we have the air, the pneumothorax. The sound is not able to penetrate, and that is why the lung movement is not seen. So in the lower part of the image, in pneumothorax, we would see the flat lines. So like we are seeing here also it is all the flat lines because the overlying air is not allowing the visualization of the lung. So this is the barcode, that is all the flat lines, the barcode or the stratosphere sign in pneumothorax. The last image is showing the most specific sign in pneumothorax, that is the presence of the lung point sign. What is the lung point? The point in the lung where basically you are seeing the transition from the seashore to the barcode. That means from the normal to the pneumothorax. So this is what we are seeing in this image. Till this point, we are seeing the seashore sign which is normal. Here is the barcode sign which is suggestive of pneumothorax. Right, so the transition from one sign to the other, that is the most specific sign for pneumothorax. In pneumothorax, the lung sliding is absent. Another feature is the absent lung sliding. Normally, the two pleura you would be able to see sliding, but here with pneumothorax, the pleural, the lung sliding would be absent. Next one, a cattle handler from a village has these complaints and the chest radiograph is shown. What is the diagnosis? So the major clue here is this is a cattle handler. So in cattle handler, the first thing that we think of is hydatid cyst. Let us have a look at the image. So what are we seeing here? There is a lesion in the chest which is showing this fluid level and the air. So there is this air fluid level, and overlying the fluid there is something floating. So this is the water lily sign. So overlying the fluid is the water lily sign. So this is suggestive of hydatid cyst. Water lily sign, hydatid cyst caused by Echinococcus granulosus. What sign are we seeing here? Here we are seeing this horizontal fissure which is bulging down. The fissure, there is something opacity above the fissure causing the bulging. So this is the bulging fissure sign. This is the bulging fissure sign which is seen with Klebsiella pneumonia. Okay, bulging fissure sign, Klebsiella pneumonia. What infection is this? This is tuberculosis. Why? Because we are seeing this miliary mottling, multiple tiny dots scattered throughout both the lungs, suggestive of hematogenous spread of the infection. And in the next image, what are we seeing is the tree in bud sign. Okay, we are seeing this tree in bud sign. What is that suggestive of? The tree in bud is basically through the bronchi, the infection is spreading, forming the nodules, that is suggestive of active endobronchial spread of infection. Okay, it is suggestive of endobronchial spread of infection. So it is not specific for TB. Any endobronchial spread of infection, any infection can give the tree in bud sign. Next one, what infection is this? Most likely this is the most common finding in COVID-19, where you are seeing there are bilateral opacities. Are these consolidation or ground glass? These are ground glass opacity because they are gray. Ground glass is gray, consolidation is completely white. So with consolidation completely white, you would not be able to see the vessels in that area. With ground glass gray, you would be able to see the white vessels in it. So here we are able to see those white vessels in the opacity areas. So this is suggestive of ground glass opacity, bilateral ground glass opacity, central or peripheral. It is most common in the peripheral subpleural area like you are seeing here. So this is highly suggestive of COVID-19. So we call it CORADS 5. Highly suggestive of COVID-19, that is CORADS 5. Next one, a 35-year-old female presenting with these complaints, HRCT is done. What is the diagnosis? So what are we seeing here is through the white lung, we are seeing the black bronchi going, right? So this is air bronchogram sign and this is seen in consolidation. So what happens normally is comparing the lung and the bronchi. The lung is also black, the bronchi are also black, both containing air. What happens with consolidation? The lung becomes white, the bronchi are still black containing air. So here you get a good contrast of white and black. Normally it's all black. So when you have two different colors coming in, it's easy to differentiate. When everything is of the same color, they camouflage each other and they are not differentiated. So basically this is air bronchogram sign, which is the black bronchi seen in the background of the white lung in any case of consolidation. So this is not only like pneumonia, any cause of consolidation, that is pneumonia, it could be pulmonary edema, it could be pulmonary hemorrhage, it could be hyaline membrane disease where you have white out lungs, right? The lungs becoming white, that gives the air bronchogram sign. And this bronchogram, bronchi are present in the lung, not outside the lung. So remember, this is a sign of parenchymal disease. If you are seeing air bronchogram sign, you are sure that this pathology is within the parenchyma, it's not outside the parenchyma. So the extra parenchymal pathologies like this, mediastinal mass, pleural effusion will not show the air bronchogram sign. Next one, differentiating the image A and the image B, which is consolidation and which is collapse. So we said that consolidation abhi humne padha, so let's differentiate consolidation from collapse. Consolidation does not cause a shift in the surrounding structures, right? Because the volume remains the same. Collapse is the volume loss. So whenever there is volume loss, the shrinkage, it pulls the surrounding structures towards itself. So what are we seeing here? This is the location of the horizontal fissure, which is maintained in its position. Horizontal fissure is normal. So this is suggestive of consolidation. Here, the horizontal fissure which should have been here has gone up. That is the fissure. So that is suggestive of collapse, which is taking the fissure up. So this is right upper lobe collapse, and above the horizontal fissure, the upper lobe, that is the right upper lobe consolidation. So in consolidation, there's no volume loss. In collapse, there's a volume loss. That is what we need to know. Next one, this is a lateral radiograph, and what do you think, which lobar involvement is this? So when you have overlying the heart a wedge-shaped opacity, think of the right middle lobe, right? So when you have a wedge-shaped opacity like this is suggestive of a right middle lobe opacity, because basically if you see the right lung, we have the horizontal fissure, we have the oblique fissure. So in between the two fissures, the part of the lung that we have is the right middle lobe. These two lines, they represent the fissures. So in between the two fissures, we have the right middle lobe. So this is right middle lobe opacity. Next one, recent NEET PG exam question as well. If you see an opacity, so basically here we are talking about the Silhouette sign, which is basically the loss of border sign. So if an opacity is causing the loss of border of the right heart, so there is some opacity here which is obscuring the right heart border. If the right heart border is obscured, the pathology is in the right middle lobe. Okay. If the pathology is obscuring the left heart border, then the pathology is in the lingula. Okay, then the pathology is in the lingula. If it obscures the diaphragm, then it is going to be in the lower lobe. So right heart border, right middle lobe, left heart border, lingula, very, very important and frequently asked. Do not confuse this with pleural effusion. That is where majority of the students made a mistake in the recent exam. Here the angle blunting is not seen, right? So this is not pleural effusion. Next one, what do you think is the diagnosis here? So what do you see are these air containing structures, the air containing structures which are dilated and thick walled. What are these? These are bronchi which are dilated. So the diagnosis here is bronchiectasis. What is the best investigation for bronchiectasis? It is HRCT chest. What signs do we see? The dilated bronchi, they give the tram track sign, and the bronchus dilated with the vessel, that gives the signet ring sign. Okay, that gives the signet ring sign. So the tram track sign and signet ring sign is what we see in bronchiectasis. Most common affected lobe in bronchiectasis is the lower lobe. Next one. Now, if I tell you that a young female patient presenting with enlargement of salivary glands, lacrimal glands and erythema nodosum, there is fatigue, there is weight loss. TB जैसे features हैं, but then there is enlargement of glands and there is erythema nodosum. What do you think of? It is sarcoidosis. Okay. So in sarcoidosis, remember you have hypercalcemia, you have increased ACE enzyme levels, which are the screening test basically here. And what do you have is erythema nodosum. Erythema nodosum, what is the first radiological finding? The most common radiological finding is bilateral hilar lymphadenopathy. Very, very frequently asked, whenever you have bilateral hilar lymphadenopathy, think of sarcoidosis. Like you are seeing here, the bulky bilateral hilar, which is suggestive of lymphadenopathy, sarcoidosis. Sometimes we might also see the right paratracheal lymph node, the right hilar, the left hilar lymph node. Then it is called as the 1, 2, 3 sign. When you do a gallium scan, a nuclear scan in this patient, these enlarged lymph nodes, the 1, 2, 3, they form the lambda. So that gives the lambda sign on the nuclear scan, that is the gallium scan. Another sign in gallium scan is this sign that you are seeing here, that is the panda sign on gallium scan. Panda sign is because of the enlarged salivary glands, the lacrimal glands and the nasopharynx showing the uptake. So panda sign is seen in sarcoidosis. The nodules here in sarcoidosis are perilymphatic nodules, which will lead to fissural nodularity on HRCT. Okay, remember on HRCT, we would see the fissural nodularity. Next one, what do you think is this occupational lung disease that we are seeing here? This is asbestosis. Why is this asbestosis? Because what are we seeing here are these calcified lesions. The calcified lesion here as well, which is suggestive of calcified pleural plaques. Okay, so basically these are calcified pleural plaques that we are seeing here. And these pleural plaques, end phase, they appear irregular like a leaf, that is called as holly leaf sign. Okay, that is called as holly leaf sign. What is the most specific tumor associated with asbestosis? It is the development of mesothelioma. Most specific, mesothelium, the pleural lining ka tumor. So the pleura will become thick and irregular. That is what we are seeing here. Look at the thickening, the irregular thickening of the pleura, right, which will involve the mediastinal pleura also. And look at the thorax ka volume. This is decreased. So this is also called as like fibrothorax. Fibrothorax, this will be PET mein, this will be positive, showing the FDG uptake. This is mesothelioma. What is this one? This is the round lesion adjacent to the pleural plaque with the vessels going towards it like a comet tail. So this is the comet tail sign, which is seen in round atelectasis. Round atelectasis adjacent to pleural thickening. Atelectasis, the round collapse pulls the vessels itself like a comet tail. So this is comet tail sign of round atelectasis. Asbestosis, remember, as base involves the base of the lung, that is the lower lobe. The occupation history generally here is the shipyard wala history. Okay, the shipyard history is what is generally given. Next one, what are we seeing here? So here we are seeing the bilateral symmetrical opacities in the lung perihilar region. This is suggestive of bat wing appearance, which is seen in pulmonary edema. Okay, this is the bat wing appearance of pulmonary edema. Next one, what is this lesion showing? So there is a lesion which is showing this chunky calcification within, which is popcorn calcification. So where do we see the popcorn calcification in the lung? It is pulmonary hamartoma. Okay, it is seen in pulmonary hamartoma. So remember, it's like hamara, tomhara, popcorn. So popcorn calcification in the lung, hamartoma, in the brain, cavernoma, in the breast, fibroadenoma, in the pelvis, uterine fibroid. Next one, what lung tumor is this? The lung tumor involving the apex of the lung. That is the Pancoast tumor, which involves the lung apex. And the question here is, what is the investigation of choice? The investigation of choice is MRI. Why? Because this Pancoast, lung apex ke yahan, you have the brachial plexus going. So we need to look for brachial plexus invasion. And for the nerves, the soft tissue, it is the MRI. So because of the brachial plexus invasion, the patient presents with the arm pain, Because of involvement of the sympathetic trunk, there is history of Horner's as well. So this is generally the history that is given along with Pancoast. So there is arm pain, there is Horner's, features like ptosis is what you would see in Pancoast tumor. Remember, the investigation of choice is MRI. Rest of the lung cancers, the investigation of choice is CT scan. Next one, what is this CT scan showing? So this is the honeycombing, the air-filled cyst one above the other. Like this is the honeycombing appearance, which is seen in interstitial lung disease, the UIP pattern or the IPF pattern. Usual interstitial pneumonia or idiopathic pulmonary fibrosis. So where you, along with that, you see the traction bronchiectasis also. This is suggestive of irreversible fibrosis occurring in the lung. So remember that for interstitial lung disease, the history is generally of dry cough. It's not productive cough. And the investigation of choice is HRCT. HRCT for bronchiectasis and interstitial lung disease. Next one, what are we seeing here? So if I tell you that this is a newborn with a respiratory distress and a scaphoid abdomen. Respiratory distress, scaphoid abdomen. So the bowel loops have gone into the thorax, making the abdomen concave, scaphoid. This is suggestive of congenital diaphragmatic hernia, where you see there are those multiple bowel loops in the thorax. The diaphragm is not seen, right? So this is congenital diaphragmatic hernia. Remember, the bag and mask ventilation is contraindicated here. The most common type is the Bogdalek hernia, which will be on the left side. Morgagni hernia will come. So when I write Morgagni, so remember it is a right and the A, the R and the A, it is right anterior. Bogdalek is ulta, it is left posterior. Right? Coming to this one, what are we seeing here in these images? So all these images are showing the diagnosis of pneumomediastinum. Remember, we are talking about pneumomediastinum, not pneumothorax. So air surrounding the mediastinal structures. So first important sign that we are seeing here is the continuous diaphragm sign. So what are we seeing here? Separating the heart from the diaphragm is this black air. So the heart and the diaphragm are separated by the air, and that is why the diaphragm is seen in continuity. That is called as continuous diaphragm sign seen in pneumomediastinum. Second one, this is the thymus which is separated from the heart. So appearing like a Spinnaker sail. So this is called as Spinnaker sail sign or the angel wing sign. When the thymus is on both the sides appearing like the wing, the angel wing sign. Next one, this is the air in the form of the V. So this is called as Neclarios V sign. Neclarios V sign. Right, all of these are signs of pneumomediastinum. Next one, again what are we seeing here? This is some air in the neck. In the neck we are seeing the air. There are some air lucencies in the pectoralis major muscle which are like appearing like a striations here, appearing like this leaf, which is called as the ginkgo leaf. So this is the ginkgo leaf sign which is seen in subcutaneous emphysema, the air in between the muscle fibers of pectoralis major, and the clinical sign that we see here is, remember, Haman's crunch. Okay, Haman's crunch seen in subcutaneous emphysema. So that was about the respiratory radiology, and now we would have a look at the cardiovascular radiology. So now we are going to learn about the important images in the cardiovascular radiology. So first one, what are the various heart appearances in the various congenital heart diseases? So the first one that we have here, very, very important, this is the boot-shaped heart that we are seeing here. So the boot-shaped heart basically is because of the upturned apex of the heart, which is because of right ventricular hypertrophy, which is seen in a patient of TOF, tetralogy of Fallot. So remember, Fallot is like falling boot. So imagine a boot falling. So it is boot-shaped heart follows, that is Fallot's tetralogy, also called as Core and Sabo. Also called as Core and Sabo. The next that we have here is this figure of 8 appearance of the heart. So above the normal heart shadow, we are seeing another shadow which is the abnormal vertical vein. This is the figure of 8 above the heart. So above the heart, so this is supracardiac TAPVC, total anomalous pulmonary venous connection, which is also called as type 1 TAPVC. The figure of 8 heart is also called as the snowman heart. Next one, what are we seeing here? This is the egg on side appearance of the heart or the egg on string appearance of the heart. So this is egg on side or egg on string appearance of the heart, which is seen in transposition of great arteries. So transposition of great arteries, the egg on side, the string represents the narrow superior mediastinum because of the thymic atrophy, the arrangement of the vessels. So this is TGA. And TGA, remember, has a high association with maternal diabetes mellitus. It is the most specific congenital, the cardiovascular anomaly in a mother who has diabetes mellitus during pregnancy, in the neonate, of course. Going on to the next one, the appearance of the heart that we see here, this is the box-shaped heart. Now, where do we see the box-shaped heart? Box-shaped heart is seen in Epstein's anomaly, which is the teratogenic effect which is seen with lithium. Epstein's anomaly, there is significant right atrial enlargement. Box-shaped heart, Epstein's anomaly, lithium teratogenic effect. Next one, what is this image showing? So if you see very carefully, there is some density that we are seeing here. Above this circular density, which represents the circular density, this represents the prosthetic mitral valve. Okay, this represents a prosthetic mitral valve. And above that, this density is the enlarged left atrium. So basically, this radiograph is showing left atrial enlargement. This is showing left atrial enlargement, which can be seen in a patient of mitral stenosis. Here, the patient has already been operated for the mitral stenosis with the prosthetic valve. So what are the signs in left atrial enlargement? First is the straightening of the left heart border. It's the left heart border which gets straightened. The enlarging left atrium takes the left bronchus up. So what happens? The carinal angle, which is normally this, now gets increased. So there is playing of the carina with the increase in the carinal angle because of the elevation of the left main bronchus. Okay, because of the elevation of the left main bronchus. Third, the left atrium comes to the right. So that gives the double density sign. Okay, that gives the double density sign that we see here. The left atrium has come to the right side. So these are the signs that we see in left atrial enlargement. And also remember that it can cause esophageal indentation leading to dysphagia. Next one, what is this image showing? So in this, the appearance of the heart that we are seeing here, this is the flask-shaped heart, also called as the money bag heart or the water bottle heart, which is seen in, remember, water is effusion. This is seen in pericardial effusion, right? The water bottle heart, it is seen in chronic pericardial effusion. And what is the CT scan showing? Surrounding the heart, this gray color, the density of the water, this is the pericardial effusion. It is separate from the heart. It is in between the two pericardial layers, that is pericardial effusion. Next one, what is this image showing? So look at the CT, there is this white calcification surrounding the heart. The white calcification surrounding the heart, even in the radiograph, we are seeing this white calcification. So this is calcific constrictive pericarditis. Okay, this is calcific constrictive pericarditis. And we are seeing the calcification here. Remember in JVP, what do we see? The M pattern is what we see in JVP. The X descent is present. The Y descent is also present. The X and the Y are present. But the Y is very prominent. Okay, the Y is very prominent. While in cardiac tamponade, the Y descent is absent. Okay, that's the difference. Going to next one, what are we seeing here? So again, this bat wing appearance in the chest that we are seeing. Bilateral symmetrical opacities with sparing of the apices and relative sparing of the lower bases. And along with that, we are seeing this short horizontal lines at the base called as the curly B lines. So curly B lines along with the pulmonary edema here, this is suggestive of congestive heart failure. This is heart failure. The left heart failure is what leads to pulmonary congestion. So this is left heart failure, which will give this cardiogenic pulmonary edema, and the curly B lines suggestive of the interstitial edema, right? The interstitial edema. Next, very important. What is this image showing? This is a CT scan, the contrast CT. The pulmonary artery showing this filling defect, this is pulmonary embolism. Okay, this is pulmonary embolism. Classical history would be first the patient has DVT leading to pulmonary embolism. What leads to DVT is prolonged immobilization, right? So recent surgery, recent like long travel, immobilization leading to DVT, leading to pulmonary embolism. And what is the investigation of choice? The investigation of choice is CT pulmonary angio. What is the first investigation? The screening test, that is the D-dimer. Okay, first is the D-dimer. What are the chest X-ray signs in pulmonary embolism? The enlargement of the right descending pulmonary artery, PAL, that is pulmonary artery large. Which pulmonary artery? The right descending pulmonary artery. This is called as the Pallas sign. Okay, that's the Pallas sign. Next that we have the infarct which presents like a peripheral opacity. That is the Hampton's hump. Okay, that is the Hampton's hump, not the Hampton's line. Remember, line is rhyming with benign. It is seen in benign gastric ulcer. So, Pallas sign, Hampton's hump, and the next is the Westermarck sign. Westermarck, read it as vascular mark. So, in pulmonary embolism, the vascular markings are decreased because of embolism. So, that is basically focal oligemia. The decreased vascular markings focally, that is the Westermarck sign. Going on to next one, what are we seeing in this image here? This is the descending aorta which has this flap dividing the aorta into two. Aortic dissection. Right, look at this here. This is the intimal flap involving both the ascending aorta plus the descending aorta. This is the arch of aorta involved where you see the dissection, the intimal flap. So, aortic dissection generally has the history of a hypertensive patient. That's the most important risk factor. Presenting with acute chest pain, acute tearing kind of chest pain radiating to the back, the interscapular area, and there is unequal blood pressure in the upper limbs. The right and the left upper limb blood pressure is unequal. So, that is aortic dissection. What is the investigation of choice? Depends on whether the patient is stable or the patient is unstable. That means systolic blood pressure less than 90. So, if the patient is stable, we can take the patient to the CT scan. So, in that case, CT angio is the investigation of choice. If the patient is unstable, that means we cannot take the patient to CT, bedside ultrasound, that is transesophageal echocardiography is what we would do for aortic dissection. And what classification do we use for aortic dissection? That is the Stanford classification. Stanford A and B. A for A involves the ascending aorta. B for below the ascending aorta. That means the ascending aorta is not involved. When the ascending aorta is involved, Stanford A, it's a surgical emergency that needs surgical treatment. Here B for we can do conservative management. If the patient is stable and there are no complications, we can do the management with B for B, that is beta blockers. Next one, all of the following can cause the appearance shown in the radiograph except what appearance are we seeing here? The inferior rib notching. Okay, we are seeing this inferior rib notching. So, inferior rib notching, what is there along the inferior border of the rib? Along the inferior border of the rib, we have the neurovascular bundle. So, the vessels pulsating cause the inferior rib notching. The nerve mass can cause inferior rib notching. So, any neurovascular cause. So, BT shunt, vascular, neurofibromatosis, neural, and coarctation of aorta, vascular. Collagen vascular disease is not a neurovascular cause. So, that will not cause inferior rib notching. Right. So, look at this one. We are seeing the inferior rib notching. There is some inferior rib notching there. Along with the figure of 3 appearance of the aorta, the figure of 3 represents this narrowing in the aorta called as the coarctation of aorta. So, remember we have the figure of 3 appearance on the chest X-ray. Okay, the figure of 3 appearance on chest X-ray. It is seen in coarctation of aorta. Classical history would be radiofemoral delay. The radiofemoral delay with intermittent claudication because the lower limb blood supply is less. The lower limb blood pressure is less than the upper limb blood pressure, and remember the association with Turner syndrome. What causes superior rib notching? The connective tissue disorders, The muscular causes like polio, rickets, these cause superior rib notching. Both superior and inferior rib notching is seen in hyperparathyroidism. Next one, what are we seeing here? So here in the barium swallow image, we are seeing this esophagus showing the indentation. There is some compression happening there. And is it anterior or posterior? Because it is towards the vertebra side, that means it is posterior. So this is showing posterior indentation of the esophagus. On the CT scan, what do we see? This is the arch of aorta giving a branch which is going towards the right side. So this is aberrant right subclavian artery, which is the last branch aberrant coming from the arch of aorta, and it goes towards the right side. So it comes from the left, it goes behind the esophagus and goes towards the right side, and that is why it goes behind the esophagus and it causes the posterior indentation of the esophagus. In front of the esophagus, we have the left atrium. So left atrial enlargement causes anterior indentation of the esophagus, right? So here, because of the esophageal indentation, the patient presents with dysphagia, which is called as dysphagia lusoria, okay, which is called as dysphagia lusoria. So that was about the CVS radiology. Now going on to the GIT radiology. So first one, very, very important, and the image itself gives away the answer. The free air under the diaphragm, the black air under the diaphragm, suggestive of pneumoperitoneum. Pneumoperitoneum is because of the air from the hollow viscus coming out into the peritoneal cavity, that is perforation. Remember, laparoscopy can also cause pneumoperitoneum because of the gas put there, right? So here the history of peptic ulcer disease is a major clue. The peptic ulcer perforating leading to pneumoperitoneum. So whenever there is pneumoperitoneum, we need to treat the patient. Surgery needs to be done. First is stabilizing. If the patient is stable, we can evaluate with CT scan to look for the site of perforation, and we need to take the patient for surgery then. So here is it observation, ultrasound abdomen, CT abdomen, IV fluids and emergency laparotomy. So what we need to do here is IV fluids and emergency laparotomy is what we need to do here in this patient. Okay? If nothing is mentioned in the clinical scenario, patient stable or unstable, go for IV fluids and emergency laparotomy. Look at this again. This is the pneumoperitoneum, the free air under the diaphragm. This is the CT scan showing the black air without the bowel markings. This is pneumoperitoneum on CT. So the most sensitive investigation for pneumoperitoneum would be CT. For air containing pathologies, it is CT scan. The next that we have here is coming to the various signs in pneumoperitoneum. What are the various signs in pneumoperitoneum? First one, this has been asked in the recent I9CT exam also. Look at this black, the lucent air over the abdomen like a football. This is called as football sign. Okay, this is called as football sign. The next that we see here is the bowel wall appearing very clear. On X-ray, normally does not appear so clear. It's because of the air inside, the air outside, giving a very distinct appearance to the bowel wall. This is called as the Wriggler's sign. Okay, this is called as the Wriggler's sign. Next one, this is the ligament appearing very clear on X-ray because of the air on either side again, giving a good contrast. This is the falciform ligament sign. All the ligament signs we can see. Whichever ligament is surrounded by air, it appears very clear on X-ray in pneumoperitoneum. So like you see here, the umbilical ligament appearing very clear, like the inverted V sign. It's because of the air on either side. Next one, if there is air beneath the central part of diaphragm, that is called as the cupola sign. Cupola is the dome, right? The dome here is the diaphragm. Decubitus abdomen sign. What decubitus it is? It is the left lateral decubitus that we do in pneumoperitoneum. The best X-ray is the chest X-ray erect. But if the patient is in a bad condition, then we do left lateral decubitus. The air goes to the right side. The liver gives a good contrast to the black air. The air from the lesser sac also comes to right side through the epiploic foramen. So remember, it is left lateral decubitus view with a horizontal beam of X-ray that we do for pneumoperitoneum. You are seeing this black air rising up, right? So that is pneumoperitoneum. Next one, this triangular accumulation of air in between the bowel loops, that is called as the telltale triangle sign. Okay, that is called as the telltale triangle sign. So all these are the important signs in pneumoperitoneum. Next one, coming to some important abdominal radiograph images, right? The first one that we see here, what are we seeing here? Look at the air in the colon. Why do I call it colon? Because I see the haustration, and the black air is cut off here. You don't see the black air beyond this point. So this is called as colon cutoff sign. Colon cutoff sign is seen in acute pancreatitis, recently asked question, because what happens is the pancreatic inflammation, it spreads to the splenic flexure most commonly, and beyond that point the colon goes into ileus like a obstruction, and there is colon cutoff sign. Other sign in acute pancreatitis on radiograph is the gasless abdomen. Okay, the other one is the gasless abdomen. Next, very important that we see here, look at the one bubble and the second bubble of air. This is called as the double bubble appearance. The two bubbles, the stomach and the duodenum. So this is seen in duodenal atresia. Duodenal atresia, which presents with bilious vomiting immediately after birth, like on day 1 or day 2. So this is duodenal atresia. Association with Down syndrome is also there. Another cause of double bubble is the annular pancreas. The pancreas, ring-like pancreas surrounding the duodenum, compressing the duodenum like duodenal atresia. Next important image here, look at this coffee bean sign. This is the coffee bean sign that we are seeing here. The coffee bean sign, where do you see the coffee bean sign? Coffee bean sign is seen in sigmoid volvulus. Okay, this is a sign of sigmoid volvulus. In barium enema, what does sigmoid volvulus show? The barium going up reaches the point of volvulus, cannot go beyond. So the barium gives this pointed appearance, which is called as bird of prey appearance or the bird beak appearance on barium enema. Next one, coming to some barium images, the important ones, image 1, image 2 and image 3. First one is the barium swallow, where you see that the esophagus in the lower end is becoming tapered, pointed like a bird beak. So this is the bird beak on barium swallow, not on barium enema. So this is suggestive of achalasia cardia. Okay, this is suggestive of achalasia cardia, the bird beak on barium swallow, because of the narrow LES. What is the gold standard here? The gold standard is manometry. What is the dysphagia more to? The dysphagia is more to liquids as compared to solids. Solids with their weight, with their pressure, they can open the LES. Liquids will have more dysphagia here in achalasia. In contrast, in carcinoma, the dysphagia will be to both the solids also and the liquids also, because it's a fixed narrowing. Next one, where you see this corkscrew appearance of the esophagus. This is the corkscrew esophagus, suggestive of the multiple spasms in the esophagus. This is suggestive of diffuse esophageal spasm. This is the barium enema, right? The barium enema with the haustrations. Look at the narrowing in the colon here, like the apple core. So this is suggestive of apple core appearance. Apple core, remember core is car. Apple core is seen in carcinoma colon. Okay, it is seen in carcinoma colon. Next one. What is this image is showing? These images are representing CHPS or IHPS, that is hypertrophic pyloric stenosis. What is the investigation of choice? The investigation of choice is ultrasound. Why? Because we want to see the hypertrophy. We want to prove the hypertrophy. Hypertrophy of what? The muscular layer of the pylorus. How do we prove that? By measuring the thickness more than 4 millimeters. This thickness can be measured on ultrasound without any radiation, and that's why it's the investigation of choice. So the pylorus is thickened, the pylorus is long more than 16 mm. So remember, thickness more than 4, length more than 16. So 4 and 4 square, 16. What are the clinical features given here? The baby will have non-bilious vomiting. The baby will have non-bilious vomiting, and it is going to be like around 3 weeks to 5 weeks, not immediately after birth. There's going to be an olive-like lump in the epigastrium representing the hypertrophied pylorus. What are you seeing in the barium meal here? The distended stomach with the narrow pylorus like a string. The pylorus stenosis, it's a narrow pylorus like a string. This is called as the string sign. Okay, that's the string sign that we are seeing. Recent INICET question as well. The string-like pylorus going into the duodenum like a mushroom. This is the other sign, that's the mushroom sign. This is an ultrasound showing the stomach with the pylorus. The pylorus is elongated. Look at the muscle thickness of the pylorus. The thickness should be more than 4 mm. What sign are we seeing here? The narrow pylorus with the thickened muscle that gives the circle and the circle. That is called as the target sign or the donut sign. Okay, that is called as target or donut sign. What is the immediate management that you need to do in this patient? It is not like directly take for surgery. First is stabilize the patient by doing the fluid electrolyte imbalance correction. The first is the fluid electrolyte imbalance correction. Next one, 11-month-old child presenting with recurrent abdominal pain. There's a mass in the lumbar region. Barium enema is shown. What is the diagnosis? So look at the barium enema. In the barium enema, the barium going up and then the barium ends here like a claw, right? The barium is going up and ending like a claw. This is called as the claw sign. Claw sign is seen in intersusception. So what happens? The barium going up, intersusception, one bowel going into other. The barium cannot go ahead, so that gives the claw sign. What is the other sign that we see? If there is some space in between the two, the intersusceptum intersuscipiens, the barium going like coiling around the intersusceptum. The next sign is the coiled spring sign. Again, a previously asked question, the coiled spring sign, and you have the claw sign. On the radiograph, you would see some vague mass in the abdominal X-ray. On the ultrasound, the inner bowel and the outer bowel, that gives the target sign or the donut sign again. Look at the target or the donut sign on the CT as well, right? So the investigation of choice is ultrasound, especially in a child. In an adult, it is CT scan, right? So this is intersusception. What would be the immediate management? Pneumatic reduction. The immediate management would be insufflate the air with the pressure of the air. This will come out the intersusceptum. Pneumatic reduction or air enema. Next one, what are we seeing here? So the sawtooth appearance. So like the sawtooth, we are seeing this outpouchings from the colon. So this is diverticulosis. The outpouchings represent the diverticulosis. That is the sawtooth appearance. What is the investigation of choice? That is barium enema. But remember, we don't do barium enema in acute inflammatory conditions. So if this turns into diverticulitis, how will we know that? The patient will have acute pain, most commonly in the left lower quadrant, because it is sigmoid colon commonly involved. In that case, in acute inflammation, we don't do barium. That might lead to perforation. So here the investigation of choice would be CECT. Next one, this triad of vomiting, distension and the sign shown is seen in which condition? So what sign are we seeing here? The air locules arranged one behind the other like a string of pearls. This is called as the string of pearls sign on the abdominal X-ray. This is seen in small bowel obstruction. So in the obstructed small bowel, the fluid in the obstructed small bowel causes the air locules trapped in between the volvulae conniventus. It pushes the air in the periphery and that leads to string of pearls sign. Okay, that's a string of pearls which is seen in small bowel obstruction. Next one, now coming to the liver lesions. Whenever you see a calcified lesion in the liver, the first thing that you should think about is hydatid cyst. Calcified lesion in the liver, hydatid cyst. Other image as in the recent exam also, within the liver there is a lesion which has some membrane-like thing floating within. So that is like the water lily sign on CT. This is the water lily sign on ultrasound. Look at how on ultrasound the cystic lesion appears black. Fluid appears black on ultrasound. Another finding in the hydatid, mother cyst with the multiple daughter cyst inside. that is the honeycomb appearance, or the cyst within cyst appearance. Okay, cyst within cyst appearance. So all this is hydatid cyst, hydatid cyst. Next one, what do you think is the diagnosis here in this image? So look at what is shown, the arterial phase, the portal phase, the delayed phase of the CT. That is basically the triple phase CT. Triple phase CT is commonly done for differentiating the liver lesions. So arterial phase, portal phase, venous phase, based on in which phase the lesion is enhancing, how is the lesion showing the washout of contrast, we differentiate the liver lesions. So remember that hepatocellular carcinoma, HCC, it is supplied by hepatic artery. The normal liver is supplied by portal vein. So what happens is when you give contrast, it first comes in the hepatic artery. The portal vein comes later on. So hepatic artery supplied lesion, that is HCC, is the one which will show the early arterial enhancement. This is what you are seeing here. This is the arterial phase, the aorta showing the dense contrast. Then the contrast in the aorta goes on decreasing. And with the arterial phase, you are seeing the lesion in the liver which is becoming more white compared to the rest of the liver. Now in the portal phase, the rest of the liver is also enhancing. This lesion is becoming darker now as compared to the rest of the liver. That means the contrast is washing out. So early enhancement with early washout of contrast is what we see with HCC. So this is HCC, right? Amoebic liver abscess will be like a cystic lesion with a thick wall, right? And there would be the history of dysentery also along with that. Look at this one. What liver lesion is this? Here you have non-contrast CT, arterial phase CT. There is this nodular enhancement along the wall. Then the rest of the phases, you are seeing the contrast increasing inside. The contrast is filling in. So nodular enhancement, early arterial phase nodular enhancement with centripetal filling in of the contrast. This is a feature of hepatic hemangioma. Okay, hepatic hemangioma will follow the aorta, right? The first will be the peripheral nodular enhancement, then the centripetal filling in of the contrast. Next one, coming to the cystic lesions in the liver. First one, the gray water density lesions without like very thin wall. These are the hepatic cyst. When the cystic lesion has a thick wall like this, then you think of the abscess. This is a liver abscess. When it is solitary, then we think of amoebic liver abscess. Here the cystic lesions, they are showing the white dot within. So in the cystic lesions, there is the central dot sign. Where do we see the central dot sign? Remember, C for C, central dot sign is seen in Caroli's disease, the type 5 choledochal cyst, that is the central dot sign. Next one, we have seen this radiograph already, the air which is cut off, that is the colon cut off sign, which is seen in acute pancreatitis. For acute pancreatitis, a better investigation is contrast enhanced CT. We do the CT severity index for acute pancreatitis. Previously, we had Balthazar scoring, right? Balthazar scoring. So, patient presenting with acute pain in the abdomen, epigastric pain radiating to the back, and increased serum lipase amylase, we think of acute pancreatitis. The first finding on CT scan would be the bulky pancreas. Any organ acutely inflamed becomes enlarged in size because of the edema. So, bulky pancreas, when it is given, suggestive of acute pancreatitis. Look at this one. What are we seeing here? The gallbladder pathologies. This is the gallbladder with the stones inside. Why do I call them stones? Because behind the stones we see this posterior acoustic shadowing. Posterior acoustic shadowing suggestive of gallstones. The investigation of choice for gallstones is ultrasound. Next one, what are we seeing in the gallbladder is those white lines coming from the wall of the gallbladder, called as the comet tail sign. Comet tail sign, remember COCO, this is seen in cholesterosis of the gallbladder, also called as adenomyomatosis. Adenomyomatosis. So basically the cholesterol deposits in the wall, they give this artifact, that is the comet tail artifact. Next one, what investigation is this? This is the ERCP. This is the endoscope that we are seeing, and this is the biliary tract that we are seeing. So this is ERCP. Remember the endoscope, the contrast appearing black because it is done under fluoroscopy. Like DSA, here it can appear black. What are we seeing here is the CBD, be it the extrahepatic CBD, the intrahepatic also, showing this beaded appearance, right? The multiple strictures, dilatation. So beaded appearance of the biliary tract, this is seen in primary sclerosing cholangitis. Remember the association with ulcerative colitis. Association with ulcerative colitis. So remember, it's a beaded appearance. Also, it gives the pruned tree appearance. The peripheral branches, the peripheral biliary tree is very narrow, cannot be seen. It also gives the pruned tree appearance. Next one, coming to this image here, image A and image B. Both of them frequently asked. So what do we see here? This is a fluid density lesion here. This is suggestive of pseudocyst. This is the pseudocyst of the pancreas. When do you call it pseudocyst? When in acute interstitial pancreatitis. That means non-necrotizing pancreatitis. After 4 weeks, the fluid collection, it forms a wall around itself like this. Then it is called as pseudocyst of pancreas. This one here is along the pancreatic location. We are seeing the calcification, the white calcification. Whenever you see the calcification in the pancreas, think of chronic pancreatitis. Chronic pancreatitis, remember C for C. Chronic pancreatitis has calcification, C for C. It has the chain of lakes appearance. The pancreatic duct is dilated. That is why MRCP is the investigation of choice. More sensitive is ERCP. Okay. So remember, in chronic pancreatitis, the pancreas is atrophic. Chronic inflammation, fibrosis, the pancreas becomes atrophic, and that is why the pancreatic duct gets a lot of space, it gets dilated. In acute pancreatitis, the bulky pancreas compresses on the pancreatic duct. There is narrow pancreatic duct in acute pancreatitis. Here we do CECT in acute pancreatitis, right? So that was about the snapshot, the important images in the GIT radiology. So now starting with the uroradiology. First question here, this is a 10-year-old patient presenting with abdominal pain, hematuria, IVP is done. What is the condition? What is the diagnosis here? So what do we see here is, this is the one kidney and this is the other kidney, both of which are coming towards the midline and trying to shake hands with each other. So that means one and the other kidney coming together. This is the horseshoe kidney. The appearance here is called as the flower vase appearance, or it is also called as the joining hands appearance or the handshake appearance. So this is horseshoe kidney. Remember the association of horseshoe kidney with Turner syndrome. What else do we see in Turner syndrome? We see the streak gonads, streak ovaries. Also it has association with coarctation of aorta, right? So now let's have a look at the various important IVP images apart from the horseshoe kidney. Very frequently asked in the exam is this one. The ureter at the insertion showing the dilatation like the cobra head. So this is the cobra head appearance of ureterocele. Remember, this is ureter, seal matlab dilatation like a pouch. So the dilatation of the ureter coming dilating like the cobra head or the adder head appearance. Next one, what do we see here? This is like the drooping lily appearance. Remember, droop is seen in dupe, that is duplication. That's the mnemonic to remember. So remember, drooping lily appearance is seen in duplication. Complete duplication is where we see the drooping lily appearance. Next one, if we have a look at this image very carefully, we see this paintbrush appearance, which is because of the dilated collecting ducts. The collecting ducts in the medulla dilated. So this is seen in medullary sponge kidney. Okay, this is seen in medullary sponge kidney. The paintbrush appearance. The paintbrush, the bristles, they also can be called as, with the multiple flowers on them, the bouquet of flowers appearance. Okay, it can also be called as bouquet of flowers appearance. Next one, in the IVP here, what we are seeing, these are the calyces which are separated away. The normal calyces close together, the calyces separated away like the spider leg because of the large cyst in between the calyces. So this is seen in autosomal dominant polycystic kidney disease. The multiple cysts spreading the calyces away like the spider leg. Okay, so that's the spider leg appearance. Next one, like this maiden waist, okay, the figure coming like this, and then there is the narrowing, the medial deviation. This is the maiden waist appearance of the ureters, and this is seen, it's because of the medial deviation of the ureters, which is seen in retroperitoneal fibrosis. The fibrosis pulls the ureters medially, right? So look at the ureter here going over the vertebra, the ureter here going overlying the vertebra. Normally, the ureters should be lateral to the vertebra. So this is the maiden waist appearance. Maiden waist appearance of the ureters seen in retroperitoneal fibrosis. Primary disease is called as Ormond's disease. Next, we have already seen, this is the horseshoe appearance. Horseshoe kidney of the flower vase appearance. The flower vase appearance of the horseshoe kidney. Going on to the next one, what do we see here in this image? So this is the ultrasound in the kidney. This is ultrasound of the kidney. This is a hyperechoic thing behind which we see the black shadow. So the posterior acoustic shadowing tells me that this is a renal stone, a renal calculus with the associated fluid in the pelvis, that is hydronephrosis. That means it is causing obstruction. What is this image showing? This is a plain X-ray of the KUB. Plain radiograph, the calcified lesion, right, which is taking the shape of the calyces. This is staghorn calculus. So staghorn calculus, because it's calcified, it will appear white on the plain radiograph itself. That's the staghorn calculus associated with Proteus infection, right? Next one, a delayed IVU of the patient is shown. What is the most likely diagnosis? Is it the staghorn, putty kidney, PUJ, or the renal cyst? Now let's have a look at the IVP. This is a delayed IVP which is already given. So what we are seeing on the right side, the kidney and the contrast going into the ureter. On the left side, we are seeing that the pelvic calyceal system is dilated, but we don't see the contrast going into the ureter. That means that there is some obstruction at this point. So at the pelvi-ureteric junction, there is the obstruction. So this is suggestive of PUJ obstruction. This is not a staghorn calculus. Staghorn calculus will be white on X-ray itself, right? So this is pelvi-ureteric junction obstruction, where the ureter will not be visualized because there's an obstruction above that. This one again is a IVP. Now, if it is not mentioned in the image, whether it's IVP or X-ray, how will you identify? Is because you can see the contrast in the other kidney and in the ureter, that means it is IVP. If it was a plain radiograph, you would not see this contrast here, right? So this is a IVP, one kidney ureter seen, one dilated kidney seen without the ureter. Again, this is PUJ obstruction. Next one. Now, these are the plain radiographs because we don't see the other kidney, the ureter, the contrast in the bladder. These are the plain radiographs, plain X-rays. And what do we see in the plain X-ray? So, this is the calculus, the staghorn calculus. And what is this image showing? The calcification in the kidney, one kidney with that lobulated appearance. This is the putty kidney, right, which is seen in late stages of TB. The calcification in the TB, the kidney becomes non-functioning. This is called as putty kidney, white like cement. That's the putty kidney. Going on to next one, a 6-year-old child with recurrent UTI and the MCU is shown. What is the diagnosis? Now, this is the micturating cysto-urethrogram. Okay, the urethra is also seen. In the cysto-urethrogram, it's the bladder and the urethra that we should see, not the ureter and the kidney. So, like discussed in the initial part of snapshot, if in the MCU, you are seeing the contrast going into the ureter and the kidney, it is suggestive of the reflux, the contraction of the bladder leading to the reflux. So, this is suggestive of vesico-ureteric reflux. The history is also supportive, recurrent UTI in a child. So, look at the contrast going into the ureter and the kidney. and this is like grade 5 bilateral VUR. If you want to see the scar in the kidney because of the VUR, then the investigation that we do is DMSA scan, a nuclear scan. If you want to demonstrate the reflux, then the investigation of choice is micturating cystourethrogram to show the active reflux into the ureter. So now summarizing everything that we have seen so far, if it's a plain radiograph, the calcification like this is the Staghorn calculus. If it's a IVP, the kidney dilated without the ureter, then it is a PUJ obstruction. You will not see the ureter here. If it's a MCU, the cystourethrogram, you are seeing the contrast in the ureter and kidney. So in a MCU, this is a vesico-ureteric reflux. Next one, now going to some bladder appearances. The first one here is the Christmas tree appearance of the bladder that we are seeing here. This is the Christmas tree bladder or the pine tree, fir tree appearance of bladder, which is seen in neurogenic bladder. This one here is the teardrop or the pear-shaped appearance of the bladder. The teardrop or the pear-shaped appearance of the bladder, which is because of the extrinsic compression, the round bladder becomes compressed. So any cause of extrinsic compression of bladder like the pelvic lipomatosis, pelvic hematoma, pelvic abscess can cause this appearance. Next one, this is the bladder with the dilated posterior urethra giving the keyhole appearance of the bladder, which is seen in posterior urethral valve. The bladder with the dilated urethra, because there's a valve here, that gives the keyhole appearance. The investigation of choice for PUV is VCUG, that is MCU. MCU is the investigation of choice. In this MCU, what do we see is there is a keyhole appearance and also the reflux is present. Both are present in this image. This one is the bladder wall showing the calcification, the white wall of the bladder, like the fetal skull calcification. The fetal skull calcification of the urinary bladder is seen in schistosoma. Which schistosoma comes in the bladder? The vesical plexus, schistosoma hematobium. Okay, schistosoma hematobium. Next one, coming to TB of the urinary tract. First one that we have seen, the calcified kidney, that is the putty kidney. The history that is generally given here is sterile pyuria. Sterile pyuria supports the diagnosis of TB. This is the beaded or the corkscrew appearance of the ureter. The beaded or the corkscrew appearance of the ureter, which is seen in TB. Because of the multiple strictures, the ureter gives the multiple strictures, gives the beaded appearance. This is a small contracted bladder. Right, because of the fibrosis in TB, the small contracted bladder, this is called as thimble bladder. Remember TB, thimble bladder, it's a small contracted bladder. Another finding that we see is the golf hole appearance of the ureteric orifice. This is seen on cystoscopy. Next one, this is a woman who's presented with abdominal pain and a previous history of seizures, and now you see the renal lesions. What is the diagnosis? So the seizures history is a supporting history to tell you that this could be tuberous sclerosis with the renal lesion, that is angiomyolipoma. But remember that tuberous sclerosis can also have RCC associated, right? So how do you identify this as angiomyolipoma? So remember that in the kidney, in the renal mass, if it is non-enhancing, that means it's a cyst. If it has a fat component, lipoma fat component, it is angiomyolipoma. If it has the solid enhancing component only, then think of RCC, any other solid renal tumor. How do you identify the fat on CT? Fat on CT appears dirty black. Why does it appear dirty black? Because of the negative HU value. Because it is less dense than water, it has a negative HU value, it appears dirty black. Air appears jet black. So in this renal lesion, what do you see is, look at this dirty black appearance of the lesion. It is not completely black, it's not air, it is fat. It is not gray, so it's not water also. And in that component, you are also seeing the vessels, right? The angio part. So these are bilateral angiomyolipomas. How will it appear on ultrasound? It will appear hyperechoic because of the fat appears hyperechoic. Same patient, CT, dirty black appearance. Let's prove it on MRI. It is fat. So when you do a T1 weighted MRI, how do I know it's T1? The CSF surrounding the spinal cord is not white. The water is not white. So this renal lesion, the T1 pay, it is appearing white. T1 white, think of fat, right? Fat is T1 white. There are few other substances also like melanin, highly proteinaceous substance. This could be fat. Now, how do I prove that this is T1 white fat only? Is by doing a fat suppressed MRI sequence like stir. So, if it is fat with the fat suppression sequence, it will become dark. So, that proves that it is fat. On the stir, this has become dark because of the fat suppression. So, this proves that this lesion is containing fat. So, this is angiomyolipoma. Look at this one also, the dirty black again, the dirty black renal lesions appearing hyperechoic on ultrasound. Remember, fat on ultrasound is hyperechoic. So, again, this is angiomyolipoma. Next one, what is this one here? The renal lesion. This is a kidney showing a lesion which is not enhancing. It does not have a, absolute wall. This is a renal cyst. No septations, no solid lesions, no calcification according to the Bosniak classification. This is Bosniak 1, a simple renal cyst, right? Nothing to be done for that. It's a simple renal cyst. So remember, for renal cyst, we have Bosniak classification, which is done on CECT. Next one, what is this? A renal lesion now having the solid enhancing component. Then in that case, we think of renal cell carcinoma. The history here would be an elderly patient with hematuria, with painless hematuria. And RCC can go into the IVC, right? The extension into the inferior vena cava. For that, the investigation of choice is MRI. For RCC itself, it is CECT. Next one, what are we seeing here? So here, what do we see is, this is the CT scan with the white bone. And this is the kidney. This is the kidney which is enlarged. Both the kidneys are enlarged and showing multiple water density lesions, the gray lesions. This is polycystic kidney disease, autosomal dominant, where you see the both kidneys are enlarged. This is a young adult male patient who can present with hypertension and renal failure, right? And this is autosomal dominant polycystic kidney disease. Look at this, the black bone, this is MRI and the cystic lesions in both the kidneys. Again, autosomal dominant polycystic kidney disease, asked in previous FMGE exam. So that was about the uroradiology, and now we are going to have a look at the important images in the OBGY part and some breast images. So first one here, very important, what do we see is, this is the ovary which is showing the small follicles in the periphery like a string of pearls appearance. So the string of pearls appearance in the ovary, also called as the necklace appearance, this is seen in PCOS, polycystic ovarian syndrome. Now, why do you see these follicles going into the periphery? Is because of the increase in the central stroma, because of the androgens. The increased central stroma pushes the follicles in the periphery, and none of the follicles are dominant follicles. All the follicles are less than 10 mm. This is PCOS, right? Here, the history would be of like, irregular menstrual cycles, oligomenorrhea, there can be infertility, all those history will be there. Features of hyperandrogenism, hirsutism, acanthosis nigricans, all those are associated. Next, in the ovary, if you see that both the ovaries here now are showing multiple follicles which are large, that is like cyst, and there is no increase in the central stroma. So, large follicles without the increase in central stroma, then you think of ovarian hyperstimulation syndrome or the theca lutein cyst in the ovary. You will differentiate that based on the background history. Hyperstimulation would be an infertility IVF patient on treatment on ovulation induction drugs, now presenting with acute pain in abdomen. Theca lutein cyst will be seen with molar pregnancy. So, in molar pregnancy, it is going to be beta HCG positive. Okay, it is going to be beta HCG positive. So, that is how we are going to differentiate the three, the PCOS, OHSS and the theca lutein cyst. Next one, very, very important, where you see this appearance in the uterus. There are those multiple cystic areas like the vesicles. This is the vesicular mole, or basically the complete molar pregnancy, which is this appearance is called as snowstorm appearance. Okay, this is called as snowstorm appearance. The history here again would be a patient with beta HCG positive complete molar pregnancy and excreting from the vagina like the bunch of grapes. That is what would be the history. The uterus size is more as compared to the gestational age, right? So this is complete molar pregnancy, snowstorm appearance. Next one, the earliest anomaly to be seen on antenatal ultrasound is anencephaly. So remember that anencephaly is the earliest anomaly that can be identified on ultrasound as early as 10 to 11 weeks. Normal anomaly scan, which is done in all the pregnancies, it is done at 18 to 20 weeks, right? That is called as the TIFA scan, targeted imaging for fetal anomalies. Here in anencephaly, as the term says, what we will see is, so look at this one, we don't see a very concrete like white, the cranial vault is not seen, the bone is not seen, so this is anencephaly. And the sign that we see here, this is called as the frog eye appearance. The frog eye appearance, because over these eyes we are not seeing the cranial vault and there can be absence of brain parenchyma also. So that is the frog eye appearance. This is anencephaly. Remember, to decrease the risk of neural tube defects, we need to supplement folic acid. Next one, in the twin pregnancy, where do we see the lambda sign and the T sign? So remember the mnemonic, which is Laddu, and this is our Modi ji, respected Modi ji, right? So what is Laddu standing for? Laddu is lambda, that is LA, which is seen in DD, that is dichorionic, diamniotic pregnancy. Modi is monochorionic, diamniotic, and Modi ji, most famous T wala in the country, right? So remember that is the T sign. So Modi is monochorionic, diamniotic, Laddu is di, it is lambda sign is dichorionic, diamniotic. So what are we seeing here in the first image here? The thick separating membrane with the lambda sign, this is dichorionic, diamniotic. This one here again is the lambda sign, suggestive of dichorionic, diamniotic. The lambda sign is also called the twin peak sign. Next one, this is a monochorion with a thin separating membrane. This is the T sign. T is monochorionic, diamniotic pregnancy, right? Monochorionic, diamniotic pregnancy. Next one, what investigation is this? This is a hysterosalpingogram, where what do you see is the uterus is deviated to one side. There is only one horn of the uterus. So this is a unicornuate uterus, which is giving the shape of banana, called as the banana uterus. Now, HSD mainly is done for the tubal patency, not for the uterine anomalies. For uterine anomalies, remember the best gold standard investigation is laparoscopy plus hysteroscopy. The best non-invasive investigation is MRI, right? Now, let's have a look at this question. This is a female with infertility, HSD is given. What do you think is the diagnosis here, right? This is not a unicornuate uterus because we are seeing the two horns. So whether it is bicornuate, it is septate, or it is uterus didelphys. Didelphys is completely separate two uterus, no fusion at all. So there will be two cervix as well, which we don't see here. Whether it's bicornuate or septate, actually it's difficult to comment on HSD. We need to do MRI or ultrasound to comment on that. So, but still here, how do we differentiate the two? So understanding the concept here, in bicornuate uterus versus septate uterus. In bicornuate uterus, the problem is the fusion problem. The lower part has fused, the upper part has not fused. So what do we see is the upper part is separated widely. In the septate uterus, the fusion has occurred, but the septum has not been removed. So what do we see? The two have fused, but the septum is not removed. So the angle is going to be less. These are going to be close cornu that we would be seeing. So that is one very important differentiating point in HSD. Here we are seeing the two cornu are close together. So most likely this is septate uterus. But ideally, this is not very diagnostic on HSD. So how do we diagnose on MRI? So look at this one. Because in septate uterus, the fusion is complete. The outer surface of the uterus is smooth. So what do we see in septate uterus? Now look at this HSD appearing black because it's a fluoroscopy. So here we see that there are like two horns. This could be bicornuate, this could be septate. Looking at the MRI, look at the outer surface of the uterus. It's a smooth surface. It's only the inner endometrium which is separate, right? So remember that this is septate uterus. Septate, S for S, is smooth outside because the fusion is complete. This one here, look at the two cornu which are very widely separated. So high chances of this being bicornuate uterus. Look at the outer surface of the uterus. They are separate, right? The outer surface is also separate. The inner surface is also separate. So this is bicornuate uterus. So this is bi completely. Bahar bhi and andar bhi, it is bi. It's going to be separate. This is how we differentiate septate from bicornuate uterus. Next one, what do you think is the diagnosis here? So in this ultrasound, what we are seeing is this one is the endometrium of the uterus. And within the endometrium, there is something, right? There's some mass within the endometrium. This is a Doppler, which is showing the vessel coming to supply that lesion within the endometrium. This is called as feeding vessel sign. So endometrium, within that is a lesion and supplying it is a vessel like a feeding vessel. So remember, this feeding vessel sign is seen in endometrial polyp. Okay, this is a sign of endometrial polyp. What is the best test to confirm that this is endometrial polyp only? This is not a submucous fibroid. Saline infusion sonography, that is sonohysterogram. So look at the image here. In the endometrial cavity, we have the fluid, the saline that we have put, right? And you see that with the saline distension, you can see the endometrial lining very well. The polyp will be within the endometrial cavity. The fibroid is leiomyoma from the muscle. It could be outside the endometrial cavity. So if you see the lesion within the endometrial cavity, it's a polyp. If it is outside the endometrial cavity, it's a fibroid. Polyp is endometrial glands. So generally it is hyperechoic. Fibroid is the muscle. So generally it is hypoechoic. Okay, that's the difference in between the two. Next one. What investigation is this and what view is this? This is a mammogram. What view of mammogram is this? This is the MLO view, the mediolateral oblique, because in oblique we are covering the axilla also. So in mammography we have two perpendicular views. One is the craniocaudal and one is the mediolateral. We take this mediolateral a bit oblique so that we cover the axilla and we can see the axillary lymph nodes as well, right? So this is the MLO view, where you are able to see the axilla part as well. It has more coverage as compared to the craniocaudal view. So it can help us identify the axillary lymph nodes. This is mammography. Does it have radiation exposure? Yes, because it's an X-ray, right? Does it have radiation exposure less or more than chest X-ray? More than chest X-ray, it's approximately equal to 20 to 25 chest X-rays. Okay, so this is mammography. What do you think is this mammography showing? What BI-RADS it is? So for a lesion on mammography or on ultrasound on MRI, we have this BI-RADS lexicon. What is the full form of BI-RADS? Breast imaging, reporting and data system. Right? So remember that BI-RADS is breast imaging. We make the images, like we take the images. Then we have reporting, make a report of that, and store it as a data, that is data system. So when in the mammography you have a lesion which has the spiculated margins like this, right? It has the spiculated margins, highly suspicious of breast cancer. Then it's a BI-RADS 5, highly suspicious of breast cancer. So remember in BI-RADS 5 we have spiculated margins and we have microcalcification. It is microcalcification that is malignant, not the macrocalcification. If this was a normal mammogram, then what BI-RADS would it be? Remember, normal is BI-RADS 1. 1 is none abnormality. Okay, that is BI-RADS 1. This is BI-RADS 5. What will be the next step if it is BI-RADS 5? It's gonna be confirm it by biopsy. So we need to do biopsy and confirm that it's breast cancer. Next one, what are you seeing here? So in this mammogram, this is a craniocaudal view, and this is the popcorn calcification, the chunky calcification. This is not malignant. So this popcorn calcification in mammogram is suggestive of fibroadenoma. Okay, this is suggestive of fibroadenoma. What do you see on ultrasound in fibroadenoma? It's a lesion which is hypoechoic and it is wider than taller. It is going in the same plane. So it goes like this. It is wider than taller. Hypoechoic, it can have lobulated margins. It is wider than taller. In contrast, a cancer, a malignant lesion is generally taller than wider, right? Because it invades the various planes. So it is taller than wider with the spiculated margins is what we see, right? So this completes the OBGY part of the snapshot. So now we are going to see the important images in musculoskeletal radiology. So first question here, this is a male suffering from back stiffness and difficulty in bending. The CD scan is shown. How this is CD scan? The white bone cortex tells me that this is CD scan. What is the diagnosis? So here the diagnosis is ankylosing spondylitis, because we see the fusion anteriorly also and we see the fusion posteriorly also. So ankylosing spondylitis, decode the term, it is spondylitis, the spine inflammation leading to ankylosis everywhere. So आगे भी and पीछे भी everywhere it would be ankylosed. Where does it start? It starts at the sacroiliac joint. It starts as sacroiliitis. And here in the question you might also be given the history of red eye, because ankylosing spondylitis is associated with uveitis. And so let's have a look at the image here, the next image that can come in the exam. The fusion in the interspinous ligament that can appear as a white line in the midline, this is called as the dagger sign. Okay, this is called as the dagger sign. So we have the dagger sign along with the fusion of the vertebra by the syndesmophytes. This is called as bamboo spine. And what do we see here? The fusion of the sacroiliac joints, SI fusion. What is the most sensitive investigation for ankylosing spondylitis? It is MRI, because sacroiliitis first will have bone marrow edema. For the marrow pathologies, it is MRI which is to be done. Next one, what do you think is the diagnosis here? There's a swelling here. We take a radiograph. We see a swelling which is expansile, right? Involving the radius, involving the joint surface also. The only bone tumor going till the joint surface, the articular surface, remember involving the joint is the giant cell tumor. Joint is giant. So this is a giant cell tumor. So remember GCT involves the epiphysis in a giant person, that means after the fusion of the skeleton, right? So let's try to differentiate between GCT and ABC, that is aneurysmal bone cyst and chondroblastoma. So remember ECG, that is involving the epiphysis, is chondroblastoma and the giant cell tumor. Giant cell tumor occurs in a giant, that means after fusion. So chondroblastoma, blastoma generally in pediatric population, this is before the fusion. And ABC is exactly opposite of the GCT. It is metaphysis. GCT is after fusion. This is before fusion, unfused skeleton. So based on that, let's have a look at the images. This is the epiphysis involved, the end of the bone, articular surface, fused skeleton. This is GCT. So this is epiphysis, fused skeleton. What do we have here? This is the epiphysis involved, unfused skeleton. This is chondroblastoma. So epiphysis, unfused skeleton. Next, what do we have? This is the metaphysis involved, unfused skeleton. This is ABC. Okay, this is aneurysmal bone cyst. So they are expansile lesions, ABC, GCT, both of them can have this soap bubble appearance because of the multiple trabeculations, right? Next one, what bone tumors are this? Here in the lytic lesion, you are seeing a falling fragment. This is called as the fallen leaf sign, which is seen in simple bone cyst, also called as unicameral bone cyst, fallen leaf sign. Here where you see this sunburst or sun ray pattern of periosteal reaction, remember sunburst, S for S, this is seen in osteosarcoma. Where you have this lamellated onion peel periosteal reaction, is seen in Ewing's sarcoma. The age group for Ewing's is a child around like 5 years. It involves the diaphysis of the bone. And remember, Ewing's also has associated fever. So it mimics osteomyelitis. Next one, what bone tumors are this? This is an outgrowth from the bone, coming out from the bone. That means that this is exocytosis. That means this is osteochondroma. Chondroma here, it's the cartilage cap which is seen here. So this is a bone tumor with cartilage cap, and for that we need to do MRI. This one here, this is the cortical thickening, the bone tumor on the cortex. This is osteoidosteoma with the central nidus. It has the central nidus. So remember, osteoid osteoma, tumor ke andar there is this another O, that's the nidus. It involves the cortex. So for that we do CT scan. For cortex, it is CT scan. The treatment of choice here, we ablate the nidus with radiofrequency ablation. So remember, radiofrequency ablation is for osteoid osteoma. Classical history would be night pain relieved by aspirin. That will be the history here. So this is where you are seeing the radiofrequency ablation being done, the nidus being ablated by the radiofrequency ablation. When you have the multiple lesions in the small bones of the hand, that is enchondroma. Small bones of the hand is enchondroma. Remember E, the fifth alphabet, the 5 fingers. Enchondroma is in the small bones. Multiple enchondromas is Ollier's disease. All E, that means it is all enchondromas. When you have a bone tumor which is going beyond the bone and which has this popcorn calcification, so popcorn calcification going beyond the bone, then in that case think of chondrosarcoma. Here the patient would be a elderly patient, the age would be more. Chondrosarcoma, that's malignant. Next one, this is a child with limb pain. The bone mineral density is normal. What is the diagnosis? So very important finding here. Look at the epiphysis which appears like a ring. So this is the ring epiphysis which is a feature of scurvy. Look at the white line of Frankel, again seen in scurvy. So this is scurvy, this is not rickets. Okay, this is scurvy. So we have this one here, the ring epiphysis called as the Wimberger's ring. We have the white line of Frankel. White line of Frankel is not present in active rickets. It is present in healing rickets when the calcium comes in with treatment. Right, so the white line of Frankel, the Wimberger's ring, the Pelkan spur, that is a metaphyseal spur there. Pelkan spur, adjacent to the white line of Frankel, the lucent zone that is there, that is called as Trummer field zone. Okay, that is called as Trummer field zone. Again, a feature of scurvy. What do you see here? So here we see the bowing of the legs. Janu varam, that is the bowing of the legs, that is a feature of rickets. What else do we see here? Look at the irregular margin. Look at the splaying, the widening of the bone. So we have splaying, right? There is fraying and there is cupping. All these are features of rickets. Okay, all these are features of rickets that we are seeing here. In rickets, what do we see is this provisional zone of calcification gets widened. The provisional zone of calcification gets widened. That's one of the early X-ray features of rickets. White line of Frankel is not seen in rickets. It is seen in healing rickets. Next one, a recent NEET PG exam question. What are we seeing here? So look at the deformity in the femur. The femur is bent like this, like a shepherd crook. This is the shepherd crook deformity of the femur. Look at the bone matrix. Look at the bone matrix. That is called as the ground glass matrix. These are features of fibrous dysplasia. Polyostotic fibrous dysplasia, along with precocious puberty, along with skin lesions, the cafe-au-lait spots. What syndrome is that? That is McCune-Albright syndrome. Right, that is McCune-Albright syndrome. The skin lesions were mentioned in the question, so that was a clue to identify that it is fibrous dysplasia. Next one, what are we seeing here? So here we are seeing the hair on end appearance of the skull, very, very frequently asked. Hair on end appearance of the skull is also called as the crooked appearance of the skull, which is seen in hemolytic anemia. It is seen in hemolytic anemia like sickle cell anemia, thalassemia or G6PD deficiency. Because of the hemolysis, the compensatory hematopoiesis makes the bone thick along with the prominent trabeculate, that is hair on end. Other skull appearances here, the small tiny lytic lesions there, that is the salt and pepper appearance of the skull. Remember, it is seen with hyperparathyroidism. P for P, the pepper, the salt and pepper or the pepper pot appearance of the skull is hyperparathyroidism. What else do we see here in the next image is, these are the well-defined lytic lesions in the skull. These are called as punched out lytic lesions or the raindrop lytic lesions, which are seen in multiple myeloma. It's going to be an elderly patient with bone pain, right? Elderly patient with bone pain, the alkaline phosphatase will be normal. On bone scan, it will show the cold spot because there's no new bone formation. When you have a lytic lesion in the skull which has this beveled margin, right, there's a lytic lesion with the beveled margin, then the diagnosis is Langerhans cell histiocytosis. In that case, it's generally a child. There could be associated history of diabetes insipidus as well. Here in the skull, what we are seeing are those white lesions. This is the cotton wool appearance of the skull. Cotton wool skull is seen with Paget's disease. Paget's is both lytic and blastic. It has a mixed phase as well. So, the cotton wool skull is seen in Paget's. Again here, the patient is generally elderly patient with cranial nerve, the foramen getting compressed, that can lead to sensory neural hearing loss because of the cortical thickening. Next one, this is a MRI. The bone cortex is black. In the MRI, we are seeing some abnormality here, which is compressing on the cord. There is involvement of the intervertebral disc also, right? Look at the normal intervertebral disc. Here, the intervertebral disc is also involved. So, whenever you have intervertebral disc involved, we should think of Pott's spine, right? The most common type of Pott's spine is the paradiscal type. The Pott's spine can go to which surrounding muscle? The abscess can go into the psoas. It can lead to psoas abscess as well. Next one, what is this image showing? So, what do we see here? This vertebra has gone in front of the sacrum, the first vertebra. So, there is this malalignment. It has slipped in front. This is spondylolisthesis. Okay, this one is spondylolisthesis, which is seen after spondylolysis. Right, the bone becomes unstable and the vertebra can go ahead. That is spondylolisthesis. Right, where do you see the Scotty dog with collar appearance? Scotty dog with collar. The dog with the collar represents the fracture that is seen in spondylolysis. Right, that is spondylolysis. A stage after that is spondylolisthesis. Next one, what is this one here? So, in the middle phalanx, we are seeing a surface which has become concave. Normally, it should be smooth. So, there is a resorption of the bone which is happening. So, subperiosteal bone resorption is a feature of hyperparathyroidism. Okay, that's a feature of hyperparathyroidism. This is subperiosteal bone resorption. And with hyperparathyroidism, what vertebral appearance do we see? Secondary hyperparathyroidism, which is seen with renal failure. R for R, it shows the Rugger-Jersey spine. Okay, the Rugger-Jersey spine. For hyperparathyroidism, the first X-ray for the bone changes we take is the X-ray hand. because it starts in the phalanges. We might also see the light thick lesions in the bone, which are called as brown tumors. So brown tumors is hyperparathyroidism. What are we seeing here? What is the labeled thing here? Is it the sequestrum? Is it the involucrum? So here what we are seeing is in the femur, the part which is inside, the very white part, the dense part, that is the dead bone. Remember, the dead bone is radio-opaque because there is no resorption happening, there is no blood supply, it is radio-opaque. The dead bone is called as the sequestrum. Okay, these are the findings in chronic osteomyelitis. So this is the sequestrum, the dead bone in chronic osteomyelitis. So that was about musculoskeletal radiology. Now having a look at some images in emergency. First one, comment whether this is FAST negative or FAST positive. What is the full form of FAST? FAST is focused abdominal sonography in trauma. No, it is not the focused abdominal sonography. Remember, we tend to make a mistake here. It is focused assessment with sonography in trauma. It is focused assessment with sonography in trauma. So, when we do FAST in any patient of blunt abdominal trauma, basically to look for whether there is bleeding from any organ by the indirect clue of looking for the presence of free fluid. So, if there is free fluid present, it is FAST positive. So, what are we seeing in this image is the black color is the fluid, right, surrounding the kidney here. So, this is the black fluid which is present, and that is why this is FAST positive. If the patient is stable, next we will go ahead and do CECT. If the patient is unstable, we need to take the patient for surgery. So, this is FAST. What is the sequence of doing the FAST? Which regions? First is the xiphisternal to look for the cardiac tamponade, then the right hypochondrium, the left hypochondrium, and the pelvis. We look for the free fluid in these areas. In E-FAST, we also look for the thoracic cavity. So, this is FAST positive or FAST negative. Again, if you see carefully, there is this black fluid there. So, fluid is present. So, again, this is FAST positive. Okay, this is FAST positive. Coming to revision of some important emergency images, we have seen this already. First one, the filling defect in pulmonary artery. This is pulmonary embolism. Next, this is the two parts of the aorta. So, this is aortic dissection. Here, this is the blood in the sylvian fissure, the sulcal spaces, the cisterns. This is subarachnoid hemorrhage. This one here, the visceral pleural line with the surrounding jet black air. This one is pneumothorax. Okay, this one is pneumothorax. Now, going to the last part, that is the NMRT, the nuclear medicine and radiotherapy. Here, we are focusing the images part. The theory part, like the half-lives, the concept, the various scans, that has been covered in rapid revision and the comprehensive, the detailed course. So, first one, identify this investigation. Very frequently asked, this is PET-CT. A normal CT scan will have the grayscale appearance, right? With the white bone. Here, along with the white bone, we have the orange areas. So, when we have an orange colored CT, it's a PET-CT, which is an example of fusion or hybrid imaging. We are combining PET with CT. Out of that, the PET is the functional imaging. The PET tells us about the function, right? The uptake of the glucose, like in FDG PET. CT is the anatomical component. Both of these, the PET also and the CT also, they have radiation exposure, right? What is this one in the thyroid scan? So, if this is the image given in the thyroid scan where the thyroid appears completely black, that means there is diffuse increased uptake in the thyroid. The black area suggests the uptake. So, in a thyroid scan, diffuse increased uptake is seen in Graves' disease. Versus, where do we see the diffuse decrease uptake? When the thyroid is burnt out, like in thyroiditis. Okay, in thyroiditis. So, Graves' disease, thyroiditis. So, in the nuclear scan, when you have increased uptake, it is called hotspot. So, diffuse increased uptake or diffuse hotspot, that is Graves' disease. Next one, what is this one? If this is a child, this is a patient presenting with bleeding per rectum abdominal pain. So, what do we see here is there is some uptake in the left side. This is labeled the left side. There is some uptake in the right lower side also. So along with the uptake in the stomach, there's also the uptake in the RIF. So there is some ectopic gastric mucosa which is present here. Where do we see ectopic gastric mucosa? In Meckel's diverticulum. So this is basically technetium 99 per technate scan, which is done for Meckel's. Why? Because this per technate is picked up by the gastric mucosa. So basically, if we see the uptake in the RIF, that is where Meckel's is present, ileum, right? So it is suggestive of Meckel's diverticulum. So remember, for Meckel's, we have technetium 99 per technate scan that is done. Next one, what are we seeing here in the bone scan? So diffuse increased uptake in the bones, and what do we not see is the kidney is not showing the uptake. So this is called as the super scan, right? The diffuse increased bone uptake without the renal uptake. This is seen in which condition? This is seen in diffuse metastasis, or it is seen in hyperparathyroidism. Hyperparathyroidism, metabolic disorders like hyperparathyroid or diffuse metastasis. What is this machine here? This is a LINAC. Okay, some overhead sort of thing which can rotate around the patient. There is no frame needed around the patient. This is LINAC, which is linear accelerator. What is it used for? It is used for radiotherapy. What does it produce? It produces X-rays and electrons. It produces X-rays and electrons. That is LINAC. Next one, where do you see the Bragg peak? Bragg peak is seen with protons. It is most prominent with protons. So what do you see with protons is, as the proton goes deep in the body, there suddenly comes a peak in the amount of radiation, the amount of energy that it deposits. So the maximum peak is at that one point. So the advantage with proton is we can concentrate all the energy, all the radiation on that one point, that is the tumor site, without affecting the surrounding normal structure. So that is why with proton, it is called as pencil beam targeted therapy is what we can give. That is why this is preferred in a child, let's say in a child with brain tumor. What would you prefer? The proton beam, because it will not affect the surrounding structures. Wherever you have the surrounding vital structures, proton beam can be used without causing damage to the vital structures. Right, so this is the Bragg peak. Remember, Bragg BR is seen with PR, that is the protons. Next one, what is this? So when you see this frame around the patient's head and this sort of machine like with the closed door, this is a gamma knife. Okay, this is a gamma knife, which is basically, it comes under stereotactic radiosurgery. Here it's a misnomer, it's not a surgery, it is just a radiotherapy. What do we do? This is done for the brain lesions, the gamma knife. We focus all the multiple beams of gamma rays on that single point. So this is gamma knife, where we need to use the Lexell frame like you are seeing here. Why is it called Lexell frame? Because the gamma knife was invented by Lars Lexell, neurosurgeon Lars Lexell. What is this gamma knife used for? Small inaccessible lesions in the brain like vestibular schwannoma, like pituitary microadenoma, commonly used for trigeminal neuralgia. Remember, this is not used for TB. For TB, we will have the AKT, the anti-tubercular treatment is what we would be using. So this is another image of the gamma knife. You can see all the gamma rays which are focused on that lesion. Around the patient's head, we have a frame. So this is gamma knife. Thinking logically, gamma knife will use the gamma rays. Cyber knife, similarly, you have cyber knife which uses X-rays. So gamma knife uses gamma rays, cyber knife uses X-rays. And what is gamma camera? Do not confuse this with gamma camera. Gamma camera takes the images. So basically it is the detector which is used in nuclear medicine. It is a detector used in scintigraphy. Okay, so remember, gamma camera is the detector. It is not used for radiotherapy. Coming to this one, an extra edge image at the end of the snapshot. First of all, this is a DSA image with the black vessel. And what do you think is the diagnosis here? Is it an aneurysm? Is it a juvenile nasopharyngeal angiofibroma? It's a caroticocavernous fistula or AV malformation. See, the aneurysm will appear like a blob of contrast around the vessel, that's swelling. JNA, it's a tumor. JNA is most commonly supplied by external carotid artery के branches से आता है. It's a highly vascular tumor. It shows a tumor blush. Carotico-cavernous fistula, it's a direct communication between the artery and the vein. So directly from the artery, the blood is going into the vein. So the vein is getting the blood early. So basically, we would see the early contrast coming in the vein. AV malformation, on the other hand, has a nidus in between the artery and the vein. There is an abnormal entanglement of the vessels called the nidus, which is present. Fistula does not have a nidus. Now, based on this, look at this. The tortuous vessel here, this is the internal carotid artery. And what we are seeing is, here is the contrast which is also coming in the cavernous sinus and the superior ophthalmic vein. So, early draining vein is what we are seeing here. Without the nidus, this is suggestive of fistula. What is generally the history with carotico-cavernous fistula? It can come post-trauma, right? After a long time, even after trauma, and the patient presents with pulsatile proptosis. Why? Because the superior ophthalmic vein drains into the cavernous sinus. The cavernous sinus has high pressure because of the fistula with the carotid. This pressure is transmitted to the superior ophthalmic vein. So we would see an enlarged superior ophthalmic vein here. So look at this MRI here. This is what we are seeing here. This is from the globe coming, the superior ophthalmic vein going into the cavernous sinus. It is enlarged. So when you have enlarged superior ophthalmic vein, enlarged cavernous sinus, early enhancement of cavernous sinus, it is a carotico-cavernous fistula. Okay, that's a carotico-cavernous fistula. What are we seeing here? Here we are seeing the abnormal entanglement of the vessels here, that is giving the bag of worms appearance. This is the bag of worms appearance, suggestive of there's a nidus, AV malformation. Okay, that is AV malformation. AV malformation, the clinical history can be of a hemorrhage because this can rupture. The hemorrhage is not in the basal ganglia. Like in hypertensive hemorrhage, the most common site is putamen. This is unusual site. This generally leads to lobar hemorrhage and it's a young patient. If it's recurrent multiple lobar hemorrhage in an elderly patient, then what do you think of? In elderly, the weak vessels, amyloid deposition, amyloid angiopathy, right? So remember, young patient lobar, AV malformation, elderly patient recurrent lobar, amyloid angiopathy, and you have a hypertensive patient with putaminal bleed, then it's a hypertensive intraparenchymal hemorrhage. This is the DSA showing this aneurysm, right? The blob of contrast that we were talking about. This is the ICA dividing into the middle cerebral artery and the anterior cerebral artery. So this is the ACA aneurysm that we are seeing here. ACA aneurysm, when ruptures, the blood will be in the interhemispheric fissure, right? The site of the blood can help us guess that what aneurysm has ruptured. So there is blood in the interhemispheric fissure, the sylvian fissure, the intraventricular. This will lead to subarachnoid hemorrhage, right? Aneurysm leads to subarachnoid hemorrhage, right? So thank you so much, everyone. This was about snapshot, the most important images for the last minute revision in radiology. You should come to this after you have decoded the black and white concepts of radiology from the main videos. If you are short of time, then first watch the rapid revision. And if you want to do then the last minute revision, then you come to the snapshot. So thank you so much, everyone. And yes, keep studying, keep revising, and keep winning.